dengan berbagai lembaga nasional dan internasional agar terus bisa mengabdi untuk bangsa dan negara. Seorang radiografer akan selalu dibutuhkan sepanjang masa. Mulailah perjalananmu menjadi seorang radiografer dari sini. Jurusan Teknik Radiodiagnostik dan Radioterapi, Poltekkes Kemenkes Semarang. Laboratorium Radiologi Poltekkes Kemenkes Semarang merupakan laboratorium pengujian yang menyelenggarakan uji kesesuaian pesawat Sinar X diagnostik dengan ruang lingkup radiografi umum atau radiografi mobile dan radiografi dental. Pelanggan laboratorium terdiri dari rumah sakit, klinik, maupun institusi lainnya. Pengujian kesesuaian dilakukan di luar lokasi laboratorium atau on-site. Keberadaan Laboratorium Radiologi Poltekkes Kemenkes Semarang diatur melalui SK Menteri Kesehatan Republik Indonesia Nomor 38 Tahun 2018 tentang struktur organisasi Direktorat Poltekkes Kemenkes Semarang, serta SK Direktur Poltekkes Kemenkes Semarang Nomor HK-03-02-1424/2020 tentang penetapan personil Laboratorium Jurusan Teknik Radiodiagnostik dan Radioterapi. Visi Laboratorium Radiologi Poltekkes Kemenkes Semarang menjadi laboratorium pengujian yang profesional dalam rangka terwujudnya pengelolaan keselamatan radiologi diagnostik berskala nasional tahun 2025. Misi laboratorium menerapkan sistem manajemen mutu secara profesional sesuai standar SNI ISO IEC 17025-2 2017. Memberikan pelayanan kepada masyarakat di bidang laboratorium pengujian peralatan radiologi diagnostik, meningkatkan kapasitas laboratorium secara kontinuerus. Laboratorium Radiologi mendapatkan penunjukan dari Badan Pengawas Tenaga Nuklir sejak tahun 2013 sebagai lembaga uji kesesuaian. Pada tahun 2022, laboratorium telah memperoleh sertifikat ISO 17025 dari Komite Akreditasi Nasional. Laboratorium Radiologi Poltekkes Kemenkes Semarang didukung dengan berbagai peralatan uji yang terkalibrasi, di antaranya survei meter gamma, X-ray multimeter, luxmeter, waterpass, beam alignment test tool, caliper, dan pantau akrilik. Laboratorium Radiologi senantiasa menerapkan ISO 17025 yang juga didukung dengan kegiatan rutin, yaitu uji banding antar laboratorium, audit mutu internal, kaji ulang dokumen, survei kepuasan pelanggan, dan rapat tinjauan manajemen.
Karena sudah terpakai ya.
Wahai generasi muda, satukan raga,
Tunas Gloria, SD. Tunas
satukan
Gloria.
jiwa, kita wujudkan kesehatan bangsa bersama, kita pasti bisa. Wahai kau sedang muda, satukan tekad, teruslah semangat, raih impian, melangkah bersama, membangun Indonesia sehat. Perbedaan bukan lagi halangan, bersatulah di Poltekkes Semarang, bersama dan berkarya, melangkah seirama, generasi muda, sehatkan Indonesia, peduli sesama, satukan rasa dan
Datang sini balik ke sana tuh waktu
kita, Poltekkes
hemat waktu datang ke sana.
mendunia.
Yang di rumah sakit Bu Ati gimana? Apa tuh? Di mana?
Bersama dan berkarya, melangkah seirama, generasi muda, sehatkan Indonesia, peduli sesama, satukan rasa dan asa, berkarya kita, Poltekkes mendunia, berkarya kita, Poltekkes mendunia.
Setiap tahun, ratusan lulusan jurusan Teknik Radiodiagnostik dan Radioterapi Poltekkes Kemenkes Semarang melakukan banyak hal luar biasa untuk dunia medis di Indonesia.
Selama 5 dekade, jurusan Teknik Radiodiagnostik dan Radioterapi Poltekkes Kemenkes Semarang mengukir sejarah di dunia pendidikan radiografer Indonesia. Ukiran penuh kelok yang menambah keindahan dalam pendewasaannya. Tinta sejarah menuliskan berbagai nama jurusan kita tercinta berawal dari APRO, Akademi Penata Ronsen, PAM RR, Pendidikan Ahli Madya Radiodiagnostik dan Radioterapi, dan ATRO, Akademik Teknik Ronsen, hingga akhirnya nama JTRR, Jurusan Teknik Radiodiagnostik dan Radioterapi Poltekkes Kemenkes Semarang, menggaung di kancah dunia.
Demi mendapatkan lulusan yang kompetitif, jurusan kami konsisten dalam pemenuhan sarana dan prasarana yang memadai. Proses belajar mengajar tak hanya berfokus pada tridharma perguruan tinggi belaka. Namun, lebih dari itu, kami membekali mahasiswa dengan berdirinya lembaga PPR dan lembaga uji kesesuaian pesawat sinar X yang didukung dengan laboratorium terakreditasikan pertama di lingkungan Poltekkes Kemenkes se-Indonesia.
Tunggu di kering, Sa.
Selamat datang di jurusan Teknik Radiodiagnostik dan Radioterapi Poltekkes Kemenkes Semarang. Kuliah di jurusan kami merupakan langkah awal dalam menyiapkan diri menjadi seorang radiografer profesional. Kami sadar bahwa kami tidak hanya membantu proses belajar menghasilkan citra guna menegakkan diagnosa. Lebih dari itu, kami membentuk mahasiswa untuk mampu memberikan sikap yang hangat dan memberikan pelayanan terbaik untuk pasien. Mereka juga disiapkan agar bisa berkomunikasi dan berbagi pengetahuan secara efektif kepada teman sejawat, masyarakat, dan pihak terkait dalam upaya peningkatan mutu pelayanan kesehatan. Setelah karakter diri terbentuk, kami membekali mahasiswa dengan keterampilan klinis satu demi satu, teknik demi teknik, dengan berbagai modalitas radiologi yang kami miliki. Memberikan pembelajaran mengenai bagaimana cara menghasilkan citra, teknik pemeriksaan, dan proteksi radiasi adalah suatu hal yang wajib bagi kami. Jiwa kompetitif kami sudah tertanam sejak pertama kali mendaftar di jurusan Teknik Radiodiagnostik dan Radioterapi Poltekkes Kemenkes Semarang. Untuk mengikuti program seleksi ini, masing-masing dari kandidat harus mengalahkan setidaknya 16 kandidat dari berbagai daerah di Indonesia. Program PKN IPC adalah salah satu inovasi dari Poltekkes Kemenkes Semarang yang memberikan pengalaman kepada mahasiswa untuk berkolaborasi antar profesi, expert, dan masyarakat melalui pengabdian kepada masyarakat dan penelitian. Jurusan Teknik Radiodiagnostik dan Radioterapi Poltekkes Kemenkes Semarang terus berkontribusi untuk bangsa hingga saat ini. Untuk itu, kami bersinergi dengan berbagai lembaga nasional dan internasional agar terus bisa mengabdi untuk bangsa dan negara. Seorang radiografer akan selalu dibutuhkan sepanjang masa. Mulailah perjalananmu menjadi seorang radiografer dari sini. Jurusan Teknik Radiodiagnostik dan Radioterapi Poltekkes Kemenkes Semarang. Attention please, ladies and gentlemen, before we start today's activities, let us to inform the second IConTRAS rules first. And this is the rules. First, participants are required to attend the virtual Zoom meeting 30 minutes before the event starts. Second, participants must turn off the mic or microphone, mute, and must turn on the camera. Participants are required to use the virtual background provided by the committee. And the next rules, change the Zoom name format for the radiographers. Name institution, for example, Kansa, Rumah Sakit Seher Bugar. And for the students, we would like to inform you to change your name in the Zoom meeting. Name, class, and strip name. For example, Ari C strip 218045. And the next rules, participants are required to maintain order and conductiveness during the webinar. Students are required to complete attendance, evaluation, and post-test on healthy and through the link sent by the committee in the Zoom chat. And from the radiographers and lecturers are expected to review and complete the materials available on the LMS or Pelataran Sehat. The passing score from the post-test is 70 to obtain a certificate. And that's the rules for the second IConTRAS 2024. We wanted to start our activity today at 8 o'clock. Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, selamat pagi, salam sejahtera, Om Swastiastu, Namo Buddhaya, salam kebajikan. Dear ladies and gentlemen, please welcome the second IConTRAS International Conference on Technology of Radiology and Applied Sciences
The Excellency Director of Semarang Health Polytechnic of Ministry of Health, Dr. Jeffrey Ardianto, Master of Applied Science, the Honorable President of Indonesian Society of Radiographers, Dr. Sugianto Sarjana Pendidikan, Master of Applied Science, as well as our speaker today. The speakers, Professor Dr. Lalit Gupta, MSc PhD, the Dean of University School of Physiotherapy and Radiology, Rayad Bahra University. Mr. Dragon Honglung Liu, External Secretary of Hong Kong Radiographers Association. And Mr. Muhammad Hairi Jahidi, Radiographers in Hospital Sultan Zainal Abidin. The Honorable the Head of Radiodiagnostic and Radiotherapy, Technic Department, Semarang Health Polytechnic of Ministry of Health. Dr. Fatimah Sarjana Sains Terapan, Magister Kesehatan. Secretary of the Radiodiagnostic and Radiotherapy Technic Department, the Head of Study Programs, lecturers, and staff of Radiodiagnostic and Radiotherapy Technic Department, clinical instructors, and also all of the invited guests. Let us give thanks for the presence of Allah Subhanahu wa Ta'ala, who has given us grace in the form of health, safety, and gifts, so that we can join in the second IConTRAS 2024 with the theme Radiology for Kidney Imaging. For your information, the International Radiology Webinar is a program organized by Radiodiagnostic and Radiotherapy Technic Department of Semarang Health Polytechnic of Ministry of Health, in collaboration with PP Pari. This activity is a form of our appreciation in conjunction to the International Radiography Day 2024. Ladies and gentlemen, allow me, Ana Septiana, as the Master of Ceremony, to guide the event. Let me convey the agenda today. First is opening. The second is singing National Anthem Indonesia Raya, Hymn and March of Poltekkes Kemenkes. Sounding of the vision and mission of Radiodiagnostic and Radiotherapy Technic Department. Prayer, program report, speech, handover, the building fund, photo session, speaker session, post-test and evaluation of the event, and the finalist closing. Ladies and gentlemen, proceeding our agenda today, we would like to invite you to listen to Indonesia National Anthem, Hymn and March Poltekkes Kemenkes.
menjaga kesehatan bangsa, menjunjung nilai-nilai kemanusiaan, berbudi luhur, berakhlak dan berbudaya. Kami Poltekkes Kemenkes Indonesia berjanji pada bangsa dan negara, bekerja profesional, berprestasi, melangkah bersama mandiri mendunia. Kami Poltekkes Kemenkes Indonesia berjanji pada bangsa dan negara, penuhi panggilan untuk mengabdi, berjuang dengan segenap jiwa raga, berjuang dengan segenap jiwa raga. Poltekkes Kemenkes Indonesia siap mengabdi nusa dan bangsa, berbudi luhur, berakhlak, berbudaya, berbakti demi tugas mulia. Poltekkes Kemenkes Indonesia bekerja profesional mendunia, semangat juang tak pernah padam untuk kesehatan bangsa, siap melangkah untuk berbakti, di Dharma sebagai pedoman kami, membangun hidup berdiri tak pernah henti untuk Indonesia tercinta. Poltekkes Kemenkes Indonesia siap mengabdi nusa dan bangsa, berbudi luhur, berakhlak, berbudaya, berbakti demi tugas mulia. Poltekkes Kemenkes Indonesia bekerja profesional mendunia, semangat juang tak pernah padam untuk kesehatan bangsa, siap melangkah untuk berbakti, di Dharma sebagai pedoman kami, membangun hidup berdiri tak pernah henti untuk Indonesia tercinta. Poltekkes Kemenkes hebat, Indonesia sehat.
Ladies and gentlemen, the next agenda is sounding the vision and mission of Radiodiagnostik and Radiotherapy Technique Department by Kansa Konita Romadoni. Time is yours.
Vision and mission of Radiodiagnostic and Radiotherapy Department. Vision: becoming a department that produces intermediate radiographers with radiation safety licenses, mastery of CT scan and IT, as well as expert radiographers in the latest imaging field, supported by managerial skills, excellent personality, and internationally recognized in 2025. Mission: first, providing radiography intermediate expert education with mastery of CT scan technology and radiation safety, excellent personality and quality assurance system, supported by measurable information technology at the end of each academic year. Second, providing high quality, up-to-date radiography and imaging expert education supported by a quality assurance system at the end of each academic year. Third, facilitating research and publication in the field of radiography and the latest imaging every year. Fourth, organizing community service activities in the health sector every semester. Fifth, improving the quality of human resources in order to support the Tridharma University. Sixth, establish cooperation with government, private, and community institutions, both nationally and internationally.
Ladies and gentlemen, before we go to further session, let's pray to the Almighty God to guide us from the beginning to the end of this event without any obstacles. The prayer will be guided by Mr. Fadli Velayani. Time is yours.
Thank you, Miss Anna. Good morning, everyone. Let us pray together for the goodness of this conference activity. I will pray in Indonesian and Islamic ways. For the adherent of other religion, we invite you to pray according to your respective faith and beliefs. Bismillahirrahmanirrahim. Alhamdulillahi rabbil alamin. Hamda syakirin, hamdan naimin, hamda yu'afi ni'amahu wa yukafi mazidah. Ya Rabbana lakal hamdu kama yanbaghi li jalali wajhika wal karimil azimi sultanik. Allahumma salli wa sallim ala sayyidina Muhammadin salatan tunjina biha min jamil ahwali wal afat wa taqdilana biha jamil hajat wa tutahhiruna biha min jamil sayyiat wa tarfa'una biha indaka darajat wa tubalihuna aqsal hayati min jamil khairati fil hayati wa ba'dal mamat. La ilaha illa anta subhanaka inni kuntu minadh dhalimin. Ya Allah, Ya Rahman, Ya Rahim. Alhamdulillah, puji syukur kita panjatkan kehadirat-Mu atas segala nikmat yang telah Engkau berikan, sehingga kita dapat melaksanakan kegiatan International Conference on Technology of Radiology and Science pada hari yang baik ini. Ya Allah, berkahilah kegiatan ini, serta kami mohon jadikanlah kegiatan ini dapat memberikan manfaat bagi kami semua, serta dapat meningkatkan pemahaman dan kompetensi kami dalam menjalankan pekerjaan kami. Ya Allah, Ya Ghaffar, Ya Rabbal Alamin, ampunilah dosa kami, dosa orang tua kami, dosa para pemimpin-pemimpin kami, dosa guru-guru kami, dan para senior serta pendahulu kami. Jadikanlah apa yang telah mereka ajarkan kepada kami dapat memberikan manfaat dan menjadi amal baik bagi beliau-beliau semua. Ya Allah, Ya Aziz, berikanlah kekuatan pada kami dalam menjalankan segala tanggung jawab yang telah diamanahkan kepada kami. Mudahkanlah kami dalam melaksanakannya dengan sebaik-baiknya semampu kami. Allahumma la sahla illa ma ja'altahu sahla wa anta taj'alul hasna idza syi'ta sahla. Ya Allah, tidak ada kemudahan kecuali yang Engkau buat mudah, dan Engkau menjadikan kesulitan akan menjadi mudah jika Engkau menghendaki. Ya Hayyu Ya Qayyum bi rahmatika astaghits. Wahai Zat yang maha hidup dan maha berdiri sendiri, dengan rahmat-Mu kami memohon pertolongan. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Wa sallallahu ala sayyidina Muhammadin wa ala alihi wa sahbihi wa sallam. Subhanaka rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin. Amin amin ya rabbal alamin. We would like to thank you for the prayer that have been offered. May the prayer that we offer together be a part of goodness for this activity. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Distinguished guests, ladies and gentlemen, the next agenda is report by the head of Radio Diagnostic and Radiotherapy Technique Department. We would like to invite Dr. Fatimah Sarjana Sains Terapan Magister Kesehatan. Time is yours.
Yeah, thank you, Mbak Ana. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera untuk kita semuanya. Good morning and best wishes to all of us. The Honorable President of Indonesian Society of Radiographers, PSR or PARI, Dr. Sugianto, Sarjana Pendidikan Master of Applied Science, MRI. Terima kasih Pak Ki sudah bergabung di tengah-tengah kami. The Honorable Director of Poltekkes Kemenkes Semarang, Dr. Jeffrey Ardianto, Master of Applied Science. The Head of Department in Poltekkes Kemenkes Semarang, terima kasih Prof. Dia, Bu Simas, Bu Kris, kemudian Bu Dr. Lani, kemudian Pak Tio, Pak Teguh, Pak Parmin, Pak Arto, terima kasih. Prof. Datuk Dr. Ahmad Zubaidi Latif, Pengarah Hospital Sultan Zainal Abidin, Malaysia. Profesor Sakinah Harits, Dean Faculty of Health Sciences, University Sultan Zainal Abidin. Head of Medical Imaging School, University Sultan Zainal Abidin, Malaysia. Dr. Sofian. Profesor Kanaka Kumari Celia from Asia Metropolitan University, AMU. Indonesian Society of Radiographers, PARI and members. President of Association of Radiographers Timor-Leste, Mr. Alberto dos Santos and members. The Chairman of PARI, Pengda se-Indonesia, PARI Jateng, PARI Kota Semarang and members. The Chairman, Indonesian Association of Radiographers Education, AIPRI. And the speakers, Mr. Dragon Hong Liu from Hong Kong, Mr. Muhammad Hairi Zahidi bin Mahazer from Malaysia, Professor Dr. Lalit Gupta, Master Science PhD from India, and Dr. Sugianto, also Dr. Jeffrey Ardianto from Indonesia. The head of study program, secretary of study program, lecturer, and clinical instructor in Department of Radiodiagnostic and Radiotherapy, Poltekkes Kemenkes Semarang, all distinguished guests, and all webinar participants. First of all, let's ask thanks to Allah Subhanahu wa Ta'ala, who gives us health and prosperity to join this event. I'm really happy to be here to welcome all of the participants of the second International Conference on Technology of Radiology and Applied Science, IConTRAS. Ladies and gentlemen, Poltekkes Kemenkes Semarang is the best health polytechnic in Indonesia. We educate students from Diploma 3 to Applied Master, Department of Radiodiagnostic and Radiotherapy Teknik, known as Jurusan Teknik Radiodiagnostik dan Radioterapi or CTRR. Consists of 3 study program, 3 years Diploma of Radiology in Semarang, 3 years Diploma of Radiology in Purwokerto, and Bachelor of Imaging Radiology Technology and Postgraduate Program in Imaging Diagnostic Technology. The Department of Radiodiagnostic and Radiotherapy Technique commit to improving the learning quality as well as expands to international network to support the institutional goals achievement. The second IConTRAS is held in conjunction with the 129 year of World Radiography Day. The topic of the second IConTRAS is Radiology Technology for Kidney Imaging, which is relevant to our focus as education center of kidney health. The second IConTRAS is attended by hundreds of participants consisting of student, lecturer, clinical instructor, PARI members, IPRI members, and other participants from Indonesia, Malaysia, Timor-Leste, Hong Kong, and India. I really appreciate your kind participation, and hopefully it can improve the networking among the participants. This event is held in collaboration with Indonesian Society of Radiographers, PARI. We also invite the faculty members of University of Sultan Zainal Abidin, UNEZA, Malaysia, ASEAN Metropolitan University Malaysia, and radiographers from Malaysia, India, Hong Kong, and Timor-Leste. So in this good occasion, allow me to convey my great appreciation to the President of PARI, Director of Poltekkes Kemenkes Semarang for the support. Also UPK Poltekkes Kemenkes Semarang, and the delegation from UNEZA, AMU Malaysia, India, Hong Kong, and Timor-Leste for the participation. Hopefully this collaboration will continue and improve the achievements among the institution. And also thank you to speakers who will bring interesting and useful topic and view for us. Have a great and enjoyable conference. Salam CTRR. I help you. Integrity, hospitality, excellent, loyalty, professional, universal. Thank you for your kind attention. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Ladies and gentlemen, the next agenda is speech. The first speech is coming from the President of Indonesian Society of Radiographers. Please welcome Dr. Sugianto, Sarjana Pendidikan Master of Applied Science. Good morning, Mr. Sugianto.
Oke, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
For the first speech, time is yours, Dr. Sugianto. Ladies and gentlemen, please wait for the President of Indonesian Society of Radiographers to join the Zoom meeting again. I'm so sorry.
Gusto ko na pakai jompo.
Ladies and gentlemen, to wait for our President of Indonesian Society of Radiographers, please listen and stay tuned to our okay.
Hello, sorry for
Yanto.
that. Yeah.
Ladies and gentlemen, this is the speech from President of Indonesian Society of Radiographers. Please welcome Dr. Sugianto. Time is yours.
Okay, back again. Sorry for that. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Honorable Bapak J.P. Ardianto, Direktur of Politeknik Kesehatan, Kementerian Kesehatan Semarang, Ibu Dr. Fatima, the Head of Department Radiology in Politekkes Kemenkes Semarang, also distinguished speakers, Professor Dr. Lalit Gupta from Rajiv Gandhi University, Dragon Hongliu from Hong Kong, yeah. He is Vice President of the Hong Kong Radiographer Association. Also Muhammad Khairi Jahidi bin Mahazar, radiographer at Hospital Sultan Abdul Halim. All participants of this international webinar, radiographers, surgeons, and radiology practitioners across Indonesia and abroad. First and foremost, let us express our gratitude to Allah Almighty for His blessing and grace, enabling to us to gather virtually at this significant event. I would like to extend my highest appreciation to Poltekkes Kemenkes Semarang through UPK SDM Kesehatan Semarang for organizing the second International Conference on Technology of Radiology and Sciences, second IConTRAS, with the radiology modalities for kidney imaging. This conference features renowned speakers from various countries who will present the latest advancement in radiological imaging for the kidneys. To all participants, I encourage you to seize this opportunity to learn from the expert in their respective field. May the knowledge gained here be implemented to improve healthcare services on both national and international levels. In closing, on behalf of the Indonesian Society of Radiographers, PPPARI, I wish you a fruitful webinar. May this event run smoothly, provide extensive benefit, and mark a significant step forward in advancing our professionalism in radiology. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thanks to Mr. Sugianto for the amazing speech. And ladies and gentlemen, it is the time for us to listen to the welcoming speech that will be delivered by the Director of Poltekkes Kemenkes Semarang, Dr. Jeffrey Ardianto, Master of Applied Science. We invite you to deliver your speech and followed by the opening of the second IConTRAS 2024.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Salam, Om Swastiastu, Namo Buddhaya, salam kebajikan, good morning, salam sehat, sehat Indonesia. The Honorable, the Chairman of the Indonesian Radiographers Association, PARI, and Head of the Health Training Center, Balai Besar Pelatihan Kesehatan Jakarta, as well as our speaker, Dr. Sugianto, SPD, Master of Applied Science, MRI. The speakers, Professor Dr. Lalit Gupta, Master of Science, PhD, the Dean of University School of Physiotherapy and Radiology, Rayat Bahra University, Mr. Drakon Hong Lung Liu, the Secretary External of Hong Kong Radiographers Association, Mr. Muhammad Hairi Jahidi, Senior Radiographer from Hospital Sultan Zainal Abidin. And then the Honorable, the Head of the Department of Radiodiagnostic and Radiotherapy Technology, Health Polytechnic of Semarang, and all staff, the distinguished guests and seminar participants. Praise to Allah Subhanahu wa Ta'ala for the Almighty, His grace and mercy. We can gather today virtually in the second International Conference on Technology of Radiology and Science, the second IConTRAS. It is my great pleasure and honor to welcome you to this event. On behalf of Health Polytechnic of Semarang, I extend my warmest greetings and highest appreciation for your participation in this virtual conference. Dear audience, the Health Transformation Program in the Ministry of Health is a strategic step to improve the quality of health services in Indonesia through 6 main pillars: transformation of primary services, referral services, financing, health resiliency, human resource in health, and health technology. Health Polytechnic of Semarang, as a health education institution, must contribute to and support it. One of our contributions is the establishment of the Sentra Unggulan Pendidikan, Center of Educational Excellence. SUP is a center of excellence in vocational health education, integrating teaching, research, and community service. With the support of modern technology and innovative approaches, we aim to produce healthcare professionals who are not only competent but also prepared to face global challenges. Distinguished guests, this seminar is an important platform for us to exchange ideas and establish collaborations among experts, researchers, practitioners, and academics of radiology and health technology across countries. The theme of the second IConTRAS is Radiology for Kidney Imaging, which aligns with the SUP of Health Polytechnic of Semarang, focusing on kidney health as a priority program. Kidney health issues are a global health challenge that significantly impacts the quality of life and health systems. Early detection and accurate diagnosis are essential to prevent serious complications from various kidney diseases. To improve the diagnosis and management of kidney diseases, the use of appropriate and effective radiology imaging modalities plays a key role. Radiology imaging modalities such as ultrasound, CT, MRI, and nuclear medicine have rapidly advanced in line with technological progress. One of the technological advancements in radiology imaging modalities is dual energy CT in kidney stone diagnostic. Kidney stones affect 10 to 15% of the global population. The diagnostic challenges in conventional city is that it only provides information on the location and size of the stone without determining its composition, which is important for treatment planning. Dual energy city, DECT, an imaging technology that uses two energy levels of X-rays, is non-invasive, requires minimal radiation dose, but produces optimal image quality. DECT can provide an accurate analysis of kidney stone compositions, high imaging accuracy, and accurate diagnostic solutions. Its modality has advantages like assessing the anatomy and the function and identifying abnormalities or pathologies of the kidney. Therefore, an in-depth understanding of imaging modality is important for healthcare professionals, especially in radiology. Ladies and gentlemen, this event is also part of the 128th World Radiography Day in collaboration with the UPK, SDM Kesehatan, Ministry of Health Semarang, and supported by PP Pari. So the scientific benefits can be enjoyed by healthcare professionals in Indonesia and internationally. On this occasion, I would like to express my heartfelt gratitude to the speakers and panelists who have graciously accepted our invitation. Your expertise and perspective are invaluable to the success of this event. To the organizing committee and all the staff who have worked tirelessly to make this event happen, thank you for your dedication and hard work. To the esteemed participants, I encourage you to engage actively, ask questions, and share your thoughts. This event can build connection globally to create a real impact. Through this conference, we hope to exchange knowledge, perspectives, and expertise, and contribute to meaningful progress in our respective fields, thereby supporting the improvement of healthcare services. I hope this seminar can provide inspiration and a useful experience for all. Once again, welcome, and I wish you a productive and enlightening day ahead. Hilir sungai tenang mengalir, airnya jernih membawa cerita. Terima kasih telah hadir, mari kita mulai seminar dengan semangat sukacita. Mawar mekar di ujung taman, berbinar indah seperti senyum kekasih. Semoga pertemuan ini membawa kebaikan, kami haturkan terima kasih.
Thank you so much.
Wassalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Om Santi 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 Om.
Thanks for the remarks and officially open the event. Ladies and gentlemen, the next session is hand over the building fund to the PP Pari. We would like to invite Dr. Fatimah, Sarjana Sains Terapan Magister Kesehatan, and also Dr. Sugianto, Sarjana Pendidikan Master of Applied Science.
Ya. Ya. Terima kasih Mbak Ana. Alhamdulillah ini sudah dihadiri Pak Ki, Presiden of Pari. Terima kasih Pak Ki sudah selalu menyemangati kita semuanya. Dan tadi sudah memberikan sambutan dari Pak Ki dan Pak Direktur, Pak Jeffrey. Pak Ki, pada kesempatan ini kami mengucapkan terima kasih dan atas dukungan yang luar biasa dari PARI ke CTRR, juga ke Poltekkes Kemenkes Semarang. Dan pada kesempatan ini kami mempersembahkan kontribusi untuk pemeliharaan gedung PARI ya sebesar Rp2.220.000. Kami berharap nanti kolaborasi kita akan menjadi semakin erat dan semoga kerjasama ini akan terus berlanjut dan PARI Indonesia semakin maju mendunia, sejahtera bersama mendunia. Bersama sejahtera mendunia. Terima kasih Pak Ki.
Baik, terima kasih kami atas nama PARI menyampaikan terima kasih dan apresiasi pada kegiatan webinar internasional ya, second IConTRAS ini. Mudah-mudahan kegiatannya lancar dan bermanfaat untuk seluruh masyarakat ya, untuk peningkatan kualitas terhadap gambar. Terima kasih ini untuk kontribusi pemeliharaan gedungnya untuk PARI. Sukses untuk semuanya. Terima kasih Bu Pan.
Terima kasih Pak Ki, sukses, sehat selalu.
Thanks to Dr. Sugianto and also Dr. Fatima. Ladies and gentlemen, this is the memorable event. We would like to invite all of the participants. Please open the camera because we have to take the photo coming from the first slide. Give your best smile. Then the next slide. Third slide. And the next one. Stay to give your best smile. Okay, and the photo session has finished. So the distinguished participants, now we are in the main event of the second IConTRAS International Conference on Technology of Radiology and Applied Sciences 2024. On this session, the committee have something special. We call it the prize from the lucky participants. So just keep in touch with this event. On the first session, we have Dr. Sugianto, Master of Applied Science, and Mr. Dragon Honglong Liu for the speaker. MRI of the kidney and palliative radiotherapy for kidney cancer will be discussed in this session. The speaker session will be guided by our moderator, Mr. Saifuddin, Sarjana Sains Terapan Magister Kesehatan. Good morning, Mr. Saifuddin.
Good morning, Miss.
Okay, for the first session, time is yours.
Thank you. Test. Are my voice audible clearly on Zoom, Miss Anna? My voice audible clearly on Zoom? Okay. Assalamualaikum warahmatullahi wabarakatuh. Best wishes to all of us. Good morning, everyone. Thank you for joining us today for our webinar, the second International Conference on Technology of Radiology and Sciences, IConTRAS. With theme in this year is Radiology Modality for Kidney Imaging. My name is Saifuddin, and I'm delighted to be your moderator for this first session panel. We are thrilled to have you with us. Today, our topic is very timely and relevant as we navigate through catastrophic disease. Understanding uronephrology becomes crucial. In this session, we are to explore MRI and of kidney and ureter, and then we have to radiotherapy in kidney and in cancer. And I'm sure you will find the insights shared in this session valuable. This first session will be delivered in a panel followed by a question and answer session. Now, I would like to introduce our esteemed speakers who will be sharing their experience and expertise with us today. First we have Mr. Dr. Sugianto, Master of Applied Science, President Indonesian Society of Radiographers, PARI, as well as Head of Jakarta Health Training Center. Mr. Sugianto is President of Indonesian Society Radiographers. He has an extraordinary education, experience, and professional career, and can be said to be a role model for Indonesian radiographers. And next, we have Mr. Hong Lung Liu, or commonly called Mr. Dragon. He is External Secretary, Hong Kong Radiographers Association. He is a senior radiation therapist, Prince of Wales Hospital, Hong Kong. He has an outstanding profession qualification and professional realization established in his CV. Okay, before we go to core of presentation, we would like to make some notes of follow. One, we hope that webinar participants can listen to this session as well. If there are any question, please all participants can use the Q&A feature to submit your question during the presentation. We will dedicate time to the question and answer session at the end of first panel. Number two, feel free to engage in chat. We would love to hear your thought, but please keep the conversation respectful and focus on today's topic. Three, there will be attractive prizes for selected questioners in the question and answer question. Okay, now, without further ado, let's get started. I will hand it over to Dr. Sugianto for the first 30 minutes presentation. Assalamualaikum, Dr. Sugianto.
Oke, salam, Pak Saifuddin. Ya.
Our President, please welcome Mr. President Dr. Sugianto. The 30-minute presentation for you, and the time is yours.
Okay, thank you very much, Pak Saifuddin, Pak Jeffrey, the Director of Politeknik Kesehatan Semarang, Ibu Fatimah, Head of Department Radiology, Politeknik Kesehatan, all of the participants, audience, and especially for Dragon Liu, our friends, my friends from Hong Kong. Thank you very much for your support for us to deliver presentation for our colleagues in here in Indonesia. Also for Dr. Lalit Gupta from India, also our friends. Thank you for your support also, and Bapak Muhammad Khairi Jahidi from Malaysia, radiographer from Malaysia. Thank you very much for the support. Okay, I will deliver in both gado-gado Pak Saifuddin, maybe in English also in Indonesia. I will share. Okay, ada yang minta bantu share barangkali. Can anybody help me to share the presentation, or I can allow me to share by myself?
Kalau dibantu share aja ya Pak Ki ya mungkin.
Okay,
Okay, thank you.
Okay, thank you very much, Bapak Ibu sekalian. This is our topics, MRI in kidneys and pretos. Next slide, This topics relate to our program in government, especially in Ministry of Health. that also in Politeknik Kesehatan Semarang, that this focus on curriculum is in uronephrology. So that's why I try to deliver this topic. I hope that it will beneficial for radiographers, especially for students and radiographers in Indonesia, especially in Politeknik Semarang. Next slide, I think. Yeah. The introduction, this is MRI. This is one of the most remarkable diagnostic technologies available today. The image of the human bodies obtained by this modality is far superior to all other methods of imaging. Yeah, this
Di
is
daerah apa nama tuh?
almost the same with CT, but the principle of how it works is different. Next slide. Magnetic strength, the field of strength of magnet used for MR is usually we using Tesla. 1 Tesla is equal to 10,000 Gauss. And if we compare to the magnetic field of Earth, it's approximately only 0.5 Gauss. So this is very, very huge, yeah, very big, very strong magnet. When we use this for medical examination. Magnetic strength used in MRI is 0.5 till right now we have already 5 Tesla. Yeah. So about 5,000 to 50,000 F5 Tesla, 50,000 Gauss is very, very strong magnet. Next slide. For the MRI, we can have image. Yeah, this is we call it T1 weighted image. This is one of the weights density contrast between any two issues in any image. Is mainly due to the T1 relaxation properties of the tissues. For T1 weighting, usually we use short TR and short TE. Next slide. And 42 weighted image is the one of intensity contrast between any two tissues of image, mainly due to T2 relaxation properties of the tissues. For the T2 weighting, we usually use a long TR and long TE, yeah. Long time repetition and long time echo. Next slide. For the T1 weighted image, usually we call it anatomical imaging, because it's a better delineation of anatomy. Also, simple fluid is hypo-intense, yeah, or black, and fat is hyper-intense, brighter. And this T1 weighted image is better for characterizing infiltration of disease process into adjacent fat plane. Next slide. 42 weighted image, usually the image is bright, yeah, because increase of water due to edema, tumor, infarction, inflammation, infections, or subdural collection. Also, in T2 weighted image, metaglobin, metahemoglobin extracellular in speckled hemorrhages also looks bright. Next slide. In tattoo-weighted image, some just look dark in low proton density or in calcification or in fibrous tissue, and paramagnetic substance such as deoxyhemoglobin, hemoglobin intracellular, iron, ferritin, hemosiderin, melanin, and protein-rich fluids usually look dark in tattoo-weighted image. Next slide. And MR urography, this is special examination usually for patient with a history of iodinated contrast allergy, patient with compromised renal function, women with a childbearing age, patient being considered for nephron sparing surgery, also in surveillance patient with high risk for renal carcinoma, yeah, and also a patient with a prior history of renal neoplasma who require surveillance. Next slide. This is the technique of urography. The most common MR urography techniques is displaying urinary tract. Can be divided into two categories, usually in static fluid MR urography, with tattoo-weighted MR urography, usually heavy tattoo-weighted image, yeah. And then excretory MR urography. This is T1-weighted MR urography. Next. Or static fluid MR urography. This is usually used heavily tattoo-weighted sequence, yeah, to image the urinary tract as a static collection of fluid, and can be repeatedly to better demonstrate the ureters in their entity of and to confirm the presence of fixed stenosis. This static fluid of MR urography most successful in patients with dilated or obstructed collecting system. Next slide. This is a static fluid of urography. This is a collecting system. This is, you can see the ureter. Yeah. Next slide. And the next one is excretory MR urography, performed during the excretory phase of enhancement after intravenous administration of gadolinium contrast. The patient must have sufficient renal function to allow the extraction and even distribution. Diuretic administration can be better, demonstrate a non-dilated system. Next slide. This is excretory MR urography. This is using contrast gadolinium, yeah, so better visualization. Next slide. Also, you can see from this MR urography, the calculi or stones appearing as a signal void in MR urography. So, and you can see this one, the dark one. Yeah. This is a calculi. Next slide. And the limitation of the MR urography, relative insensitivity for renal calculi, and relatively long imaging times, and also lower spatial resolution compared to CT and conventional radiography. The next slide. For the kidney in MRI, MRI permits separate visualization of renal cortex and medulla on both T1 and T2 weighted image. On T1 weighted image, renal cortex appear brighter than medulla. Calyx are not generally well visualized, and on MRI, visualization of cortex, medulla, and renal pelvis enhanced by contrast agents like gadolinium. And renal sinus fat is observed as high intensity structure in both T1 and T2 weighted image. And para-aortic lymph nodes are visualized if they are more than 1 centimeter. Next slide. This is some MRI protocol. It is not limited. This protocol usually depend on the case. We use T2 Haste or single shot fast spin echo. This is very rapid. It provides good anatomy to overview the abdomen, and fluid containing structures look bright. Also, we using T1 gradient echo. It will fat will appear bright, and complex fluid, also bright, and adenopathy is easily visualized. And T1 gradient echo with fat saturation, it is fat containing structure become dark, and complex fluid remain bright. Next slide. Also, we usually use T1 gradient echo 3D dynamic sequence. This is after intravenous administration of CAT. The enhancement within any portion of mesh or cyst is consistent with neoplasm. And also from this sequence, the vessel will enhance. We also use MR angiography or MR venography, the vessel enhance, allowing for detection for renal vein and IVC involvement. Also for vascular anatomy, you can look and map the vascular anatomy of the kidneys. Next slide. In kidney, usually we also use diffusion weighted imaging. This is a study is still progressing. That show the good correlation between GFR and IDC, apparent diffusion coefficients. Highlighting the potential role for evaluating renal dysfunction in native kidneys. We usually the creatinine, orium high, and then we can use this diffusion weighted imaging to highlighting the potential to evaluate the renal dysfunction, which one is left or right of the kidney. Next slide. This is the picture of diffusion weighted. Next slide. This is also the MR rhinography. It is one application for dynamic contrast enhanced MRI, specifically the use of gadolinium-based contrast agent for measuring GFR. It is the function of the kidneys. Most gadolinium chelates have favorable renal properties. It is freely filtered and glomeruli without tubular secretion or resorption. transit of the bolus of contrast from the artery to the renal cortex, estimate the renal perfusion. Also, transit from cortex to medulla reflects the glomerular filtration. And finally, from the medulla into the collecting system reflects the tubular function. This is, we to know how the function of the kidneys. Next slide. Old MRE, this is blood oxygen level dependent. MRE depend on due to relaxation time, can be used for non-invasive but direct measurement of renal oxygenation. This is also exploit the paramagnetic effect of deoxyhemoglobin for acquisition of image sensitive to local oxygen concentration. The application in the context of renal artery stenosis, also in renal allograft dysfunction and diabetic nephropathy. Next slide. In MRE renal masses, the ability of MRE to characterize renal mass has improved with the development of the coils, with fast array multi-coils. Also, fast breath-hold imaging, usually use parallel imaging, and the use of gadolinium TTPA contrast enhancement. The protocols vary widely, but usually include pre and post contrast T1 weighted images with and without fat suppression. The coronal and sagittal planes are helpful for evaluating the extent of lesions, and MR angiography can demonstrate the renal arteries and veins and the inferior vena cava. Next slide. The first one is renal cell carcinoma. Renal cell carcinoma is the commonest renal malignancy, comprising about 85% of all malignant renal tumors. It occurs bilaterally in 2 to 3 and until 5% of cases. Most cases arise spontaneously in the 5th to 7th decade, and the renal cell carcinoma is in about 36% of patients with von Hippel-Lindau disease. And there is also increased incidence of renal cell carcinoma in patients on long-term hemodialysis. Next slide. Renal cell carcinoma is the next slide. Next slide. Yeah. Renal cell carcinoma and MRI. This is how to image the characteristic of the tumor. Yeah, correlate well with the course of pathology. In T1 weighted image is usually iso intense, same signal as kidney, or hypointense or dark, yeah, but highly variable because of signal from necrosis or hemorrhage. In T2 weighted image is variable, but usually slightly hyperintense or bright. Next slide. With gadolinium, tumor will enhance, but less than normal renal parenchyma. Enhancement represent viable tumors, and the lack of enhancement suggests necrosis or cystic formation. Next slide. Next slide, okay. Next slide, yeah. This is the image of T1 weighted axial. Mary shows the hypointense, the dark right midpole renal masses. The arrow, the white arrow. This is all T1 weighted coronal. Shows the hypointense right midpole renal masses. And T1 weighted postgadolinium coronal image shows the enhancing renal masses. Next slide. The MR imaging appearance of clear cell RCC varies depending on the presence of hemorrhage and necrosis. Clear cell RCC most frequently demonstrate a signal intensity similar to that of the renal parenchyma on T1 and increase signal intensity on T2 weighted image. Loss of signal intensity within the solid portion of clear cell RCC and on opposed phase image compared with in-phase image. This is due to cytoplasmic fat and has been observed in up to 60% of these tumors. The central necrosis is common and is typically seen as homogeneous hypointense area in the center of the mass on T1 weighted images. On T2 weighted images, necrosis tend to have moderate to high signal intensity, although occasionally it might appear hypointense. And in the presence of central necrosis, a solid rim of tumor is frequently seen at the periphery of the mass. And post-contrast image demonstrate the lack of enhancement in areas of necrosis and marked enhancement in the viable components of the tumor. Next slide. This is the clear cell RCC, renal cell carcinoma, in 52 years old man, axial in phase T1 weighted image. They show a right renal mass with a thick rim of tumor. The signal intensity of the rim is similar to that of the renal cortex. Central low signal intensity area is also present. Next slide. This is on the axial opposed phase T1 weighted MR image. The mass appears homogeneous and is hypointense relative to the renal cortex. So, next slide. For the predominantly cystic RCC, on the coronal single shot fast-spin echo T2 weighted image shows a mass in the upper pole of the right kidney with predominantly high signal intensity that is suggestive of fluid contents. Small nodule with intermediate signal intensity is noted centrally at the confluence of thin septa. Next slide. This is coronal subtraction image, post-contrast nephrographic phase data and pre-contrast data. So enhancement of the small central nodule within the mass. Next slide. In RCC, also we have papillary RCC. It accounts for approximately 10 to 15% of all RCCs and maybe multifocal, maybe type 1 or type 2. Next slide. This is low-grade papillary RCC in 70 years old women. You can see the coronal fat saturated steady state fast-spin echo T2 weighted shows a small mass in the upper pole of the right kidney. The mass is homogeneously hypointense relative to the adjacent renal parenchyma. Next slide. On sagittal oblique subtraction image, the mass, the arrow, enhanced homogeneously and less than the normal right kidney. Next slide. For the high-grade papillary RCC, the 70-year-old man, this is a sagittal unenhanced 3D fat set. Gradient echo, the one-weighted image, shows a large heterogeneous mass. The hyperintense component is consistent with blood product, and the peripheral anterior area of the mass, arrowheads, is clearly hypointense relative to the hemorrhagic component. Next slide. On the sagittal July venous phase image, it is obtained after the administration of gadolinium-based contrast material. The peripheral area, the arrowheads, is slightly less hypointense relative to the larger central portion, a finding that suggests that the presence of enhancing solid component. Determination of tumor enhancement is challenging on the basis of these findings alone. Next slide. On post-contrast subtraction image, data from DNA and then subtracts from those pictures, the enhancement of the peripheral component of mass arrowheads is readily visible. Next slide. And next is chromophobe renal tumors. This is count for approximately 10 to 11% of RCCs. The central necrosis might be absent, even in very large chromophobe carcinomas. Although the imaging features of chromophobe RCC can be identical to those of clear cell RCC, the chromophobe subtype tends to have a better prognosis. The next one is the transitional cell carcinoma. This is for the CCC is the second most common renal neoplasm in adults. It's most common in urinary bladder, followed in frequency by ureter and pelvis. And the incidence of the TCC is more common in males in the 7th decade. They commonly present with hematuria and flank pain. Hematogenous spread is less common than RCC, but lymphatic spread occurs earlier. Next slide. This is the TCC. It's much less common in the upper tract than in the bladder. However, it accounts for 90% of all tumors that arise from the renal pelvic urothelium. It's typically isointense relative to the renal medulla on T1 weighted image. And larger infiltrative tumor might be obliterate the fat in the renal sinus, which might appreciated on T1 weighted image without the use of fat saturation technique. And the appearance might mimic the so-called faceless kidney described in the presence of duplicated collecting system. Coronal contrast enhanced T1 weighted image are helpful in distinguishing between these two conditions. Bright signal intensity due to urine and the collecting system on the weighted image provide excellent soft tissue contrast for the detection of this tumor, which are characteristically seen as hypointense failing defects. Infiltrative DCC can be seen on a single shot T2-weighted image as a hypointense tissue mass infiltrating the renal parenchyma, which has intermediate signal intensity. Next slide. This is coronal contrast enhanced, MIP, obtained after administration 10 milligram furosemide clearly depict the lower calyx, the strike arrow, and the lower pole, the dot line of the left kidney. Note that the normal enhancement of the lower pole of the right kidney, arrowheads, and the extracted contrast material in the lower pole calyx. This is a curved arrow. Next slide. This is a coronal contrast enhanced 3D arterial phase. Shows the infiltrating mass that involve the renal sinus and the lower pole of the left kidney. Next slide. This is renal lymphoma. The 31-year-old man with recurrent mediastinal lymphoma and an enlarging renal mass is sagittal contrast enhanced PET saturated subtraction. Reveals a well-defined homogeneous hypoenhanced mass. Lymphoma was confirmed with percutaneous biopsy. Next slide. The next type is squamous cell carcinoma. As of the renal pelvis is relatively rare. This is rare tumor, highly aggressive with a poor clinical prognosis. It's often involved the renal parenchyma and perinephric tissue and might present with metastasis. In cross-sectional imaging, this cannot be differentiated from transitional cell carcinoma. Next slide. This is all of my presentations. Thank you very much. Hope this useful for all the audience. Thank you.
Sukianto for that insightful presentation. Will you stay in Zoom to next Q&A discussion? Next, we have Mr. Hong Lung Liu, or commonly called Mr. Dragon. He is external secretary of Hong Kong Radiographers Association, or HKRDA. He is a senior radiation therapist from Prince of Wales Hospital, Hong Kong. And next, we move on to Mr. Hong Lung Liu. Mr. Dragon or Mr. Dragon, please share your insightful with us. Time is yours.
Good morning. My name is Dragon Liu. I am honored to be invited by Paris to speak here. I'm a radiation therapist in Hong Kong, working in the Prince of Wales Hospital. Today, I would like to share the topic radiotherapy in kidney cancer. I will cover several topics today, as shown on the screen. First, I will share about what is kidney cancer. Then we will explore the risk factor and the symptoms and discuss the diagnosis and treatment option. I will also explain the role of radiotherapy in the kidney cancer. the technique used, contraindication, and its side effects. Finally, I will talk about the advancement in radiotherapy and the multidisciplinary approach to managing kidney cancer. Let's begin with the kidney cancer. Kidney cancer, also known as renal cancer, is starts in the kidney, the two beam-shaped organs located in the lower back of our body. The most common type is renal cell carcinoma, RCC. The most common type is renal cell, making up about 85% of the case. Other types include transitional cell carcinoma and Wilms tumor, which is more common in children. Okay, what is the cause of kidney cancer? It is often linked to certain habits, such as smoking, obesity, and high blood pressure. Family history and genetic condition like von Hippel-Lindau disease can also play a role. What is the symptom of the kidney cancer? When a patient suspects to have kidney cancer, symptoms of kidney cancer include blood in the urine, persistent back or side pain, unexplained weight loss, fatigue, and fever. If you notice these symptoms, it's important to see a doctor to check is it anything going wrong. The diagnosis of kidney cancer, we are mostly like to use different medical imaging modalities like CT, MRI, and ultrasound. From the pictures here, you can easily distinguish the abnormality of the kidney, whatever in CT, MRI, and ultrasound. In the CT image or the yellow arrow, you can see here is the abnormality enlargement of the kidney. This is abnormal. It's abnormal appearance. For the MRI, you can easily to see the mass here, and for the ultrasound, you also can easily to figure out the kidney has some problem. Besides the imaging modality, blood tests and urine tests also very important to detect the cancer marker, and the biopsy also can determine the cancer type. For the treatment, there are different modalities in treatment kidney cancer. The common and majority treatments are surgery and systemic therapy. The common surgery is so-called nephrectomy. It's a standard of localized disease. Besides, systemic therapy like target therapy and immunotherapy are using in advanced stage of the kidney cancer. Maybe we have a question. How about using the radiotherapy in kidney cancer? So, let me talk about the radiotherapy now. As we all know, radiotherapy is known as radiation therapy. It's a medical treatment that uses high dose of radiation to kill cancer cells and shrink the tumors. The radiations can be delivered externally from a machine outside the body or internally by placing radioactive material inside the body near the cancer cells, so-called brachytherapy. Radiotherapy can be used to treat cancer by destroying cancer cells, reduce the size of tumor before surgery, or prevent the cancer from returning after surgery or the chemotherapy. It can alleviate symptoms caused by cancer, such as pain or bleeding. Radiotherapy also works by damaging the DNA of cancer cells, which makes it difficult for them to continue to grow and divide. Normal cells can also be affected by radiation, but they are generally better at repairing themselves compared to cancer cells. Why radiotherapy is not the first-line treatment in renal cell carcinoma is because renal cell carcinoma are radio-resistant. Renal cell carcinoma are generally less sensitive to radiation compared to other cancer types. This makes radiotherapy less effective as primary treatment. Besides, surgery, such as nephrectomy, removal of the kidney, is often more effective in managing localized renal cell carcinoma. It provides a definite removal of tumor, which can lead to better outcomes. Besides, advancement in systemic therapies such as target therapies in immunotherapies have shown success in treating renal cell carcinoma, especially in advanced stage, and are often preferred over radiotherapy. So, the role of radiotherapy are mainly stay in palliative intent or the last option of the treatment choice in renal cell carcinoma. For metastasis RCC, it is used palliatively to relieve symptoms such as pain or bleeding, especially in case of bone or brain metastasis. And the radiotherapy also using in the post-surgery, but in rare case, it may be used after surgery if there are residual tumors that cannot be completely removed by surgery. And for the local recurrence, it can be considered for local recurrence when surgery is not feasible. And for some patients unsuitable for surgery, who can consider to manage the symptoms. Let's talk more about the radiotherapy in kidney cancer. The role of radiotherapy varies with cell type and situation. For renal cell carcinoma, is often used palliatively, like I mentioned before. For metastasis renal cell carcinoma, radiotherapy is used for palliative purpose to relieve the symptoms like pain from bone metastasis or brain metastasis. Or for the local control, in case where surgery is not possible, radiotherapy might be considered for local control of the tumor. For the transitional cell carcinoma type, it originates in the renal pelvis and ureter, often more responsive to radiotherapy compared to renal cell carcinoma. So for this cell type, we can still use radiotherapy to treat. And the last option is for the palliative care. Radiotherapy is used to relieve symptoms and improve quality of life in advanced stage, regardless of any cell types. So, the types of radiotherapy to treat the disease are the major types are stereostatic body radiotherapy, so-called SBRT, and external beam radiotherapy, EBRT. SBRT is high precision and need fewer sessions and suitable for certain metastases. For external beam radiotherapy, we mostly use the traditional way to use the treatment for mainly for palliation care. Let me talk more about the SBRT. SBRT delivers the high-dose radiation precisely, sparing healthy tissue, is aimed for local control, delaying progression, and potentially extending the patient's survival. It's effective for lung, liver, or brain metastasis, and offers a non-invasive option with fewer side effects. From the diagram, you can see the tumor is a round shape here. The high dose region is in green color and red color, so it's more localized to use the SBRT to treat the tumor, and the surrounding organ is less harm to the surrounding tissue. There is normally no radiation dose effect to the surrounding tissue. In the dosimetry aspect, SBRT use high dose fraction, typically 3 to 5 fraction, with dose ranging from 8 to 20 gray per fraction. It requires high precision planning with advanced imaging like CT, MRI, or PET, are used for precise tumor delineation. And also, the high precision planning requirement also need sophisticated planning software to ship radiation dose to the tumor is very important. Besides, in the CT scanning, we also apply the 4D CT scanning to the SBRT treatment. It accounts for tumor motion. And before the treatment, SBRT, we will apply for the IGRT technique. IGRT is meaning we can accurately deliver by using the imaging before each session of treatment. From the picture, you can see the cone beam CT image from the treatment machine before the first treatment start. We will do the comparison with the planning CT to make sure the treatment position is identical with the planning. So the IGRT is help a lot to reduce the side effect of the patient. For the external beam used in renal cell carcinoma is commonly used for bone metastasis to relieve pain and focus on improving the quality of life. In this picture, we are commonly use the two-direction AP opposing technique to cover the large size tumor in a palliative intent. This is a very simple technique. It's normally give around 3 Gray times 10 fraction to the patient to relieve the. Comparing those prescription, SBRT usually involve 3 to 5 fraction, around 8 to 20 grays, depend on the target. And while external beam radiation therapy often offer 20 to 50 gray to 30 grays in 5 to 10 fraction, is aimed to relieve the symptoms. Okay, let me discuss about the radiotherapy side effects and the side effect management strategy. The common side effects include fatigue, skin reaction, nausea, diarrhea, and pain. Management involves supportive care, medication, and a life change. Okay, let's talk about the fatigue. The fatigue is caused by radiation-induced energy depletion. We suggest the patient to have more rest, balanced diet, and do some gentle exercise to relieve the fatigue. For the skin reaction, you can see on the picture, it is very normal radiation-induced side effect to the skin when it appears redness, dryness, peeling, blistering. We suggest the patient if they suffer the skin reaction, try to use mouth soaps, moisturizer, and avoid the sun's exposure. For the nausea and vomiting, is also very common in the side effect of the radiation therapy. The cause is because the radiation to the abdominal area can irritate the stomach and digestive system. It causes and the diarrhea also. The radiation also impacts some intestine lining, so the patient will somehow will feel abdominal pain and cause a diarrhea. Nausea and vomiting can be managed with antiemetic medication, and more frequent meal is suggested. Diarrhea requires hydration, dietary adjustment, and anti-diarrhea medication. And the pain is also the common for the advanced stage patient. Pain management involves analgesic medication and suggest the patient to undergo the physiotherapy to have some relaxation technique, take more rest, and to relieve the pain. Moreover, the side effect also impact the kidney function. The kidney is need to closely to monitor. Monitoring the kidney function is crucial with regular tests and neuroprotective strategy. The neuroprotective strategy tries to protect the kidney not for further harm by the radiation. We can suggest the patient to do some hydration, ensure adequate fluid intake to maintain kidney function, and flush out the toxins. Radiation shielding, we are using the techniques to minimize radiation exposure to healthy kidney tissue, and we carefully planning and limiting the radiation dose to the kidneys. And for the medication, administering the drugs that protect kidney function or reduce radiation effects, and we will regular to checking the kidney function through the blood test to detect any early signs of damage. And nutrition support is very important to provide the patient a diet to support kidney health, often low in certain minerals like potassium and phosphorus. Okay, let me talk about the contraindication. Whatever stereostatic radiotherapy or EBRT, there are contraindication of radiotherapy. For the SBRT, the contraindication is the tumor size, because SBRT typically is suitable for SBRT is for the small tumor. Largest tumor may not be effectively treated due to the difficulty in achieving uniform dose coverage. Secondly, for the motion management, for the SBRT, tumors in areas affected by the breathing, especially the lungs, tumors in areas affected by lung require careful management to account for the movement. Otherwise, the lung tissue or surrounding tissue may be overdosed. And the location of tumor, if the tumor near the critical structures like spinal cord, major blood vessel, may pose a risk of damage to the high dose. So if the tumor is very close to this essential organ at risk, some of the tumor cannot be treated by radiotherapy. And for some patient, if the patient with the multiple metastasis is not ideal for a patient with widespread metastatic disease, where systemic therapy may be more appropriate for this type of patient. And the radiotherapy is also limited to the very poor function kidney. Radiotherapy to the kidney area can further impair the kidney function. So pre-existing kidney issue may contraindicate for this use. And if the patient prior have radiation exposure, it will increase the risk of severe side effects due to accumulative dose. So it is very careful to check the patient whether he or she have radiation treatment before. And the patient with poor overall health or those unable to tolerate potential side effects I mentioned before, it may not suitable for patient to do the radiation treatment. A multidisciplinary approach is vital in kidney cancer management. It involves collaboration among specialties like oncologists, radiologists, surgeons, and other specialties for comprehensive care and improved patient outcome. And nowadays, the advance in radiotherapy also have a great impact to the patient. Radiotherapy techniques have greatly improved in recent years, like image guided radiotherapy. It's enhanced the treatment accuracy. In the future, more research should focus on combining radiotherapy with systemic therapy in the kidney cancer is recommended. To conclude, radiotherapy is not typically the first-line treatment for renal cell carcinoma due to the radioresistance of renal cell carcinoma. Specified types of radiotherapy may be used for RCC, particular SBRT, and external beam radiotherapy. The side effect of radiotherapy for renal cell carcinoma can vary depending on treatment area and dose. Common side effects include fatigue, skin reaction, nausea, vomiting, diarrhea, pain or discomfort, and kidney function impact. In general, radiotherapy is more commonly used for symptom control rather than as a curative treatment in a kidney cancer. This is the reference of my presentation. I really hope this presentation can let you know more about the radiotherapy, the role of the radiotherapy in the renal cell carcinoma. Thank you.
Okay, thank you very much for Mr. Dragon. That was incredibly informative, especially the part about your expert in radiotherapy and renal cell carcinoma (RCC). We hope that participant can actively participate. Please write question and the chat Zoom. Yes, please write your question in the chat Zoom. Or we also invite participants to submit a question directly on Zoom. Please raise hand and open mic. Okay. And next, thank you for all speakers for sharing their expertise. Next, we wait to Q&A session. Yes, we have some questions from the audience. We check on the Q&A feature. Wow, notification and the chat Zoom. I think not yet.
Thank you very much.
You're welcome. I'm so happy to see you here.
Yeah.
Actually, we hope we can have more collaboration with Indonesia in the future.
Okay. Yeah. Last 2 weeks, I think our friends come to discuss to you about the collaboration, right? Yeah. I hope that it will continue.
Okay. Thank you.
Thank you. Yeah. Thank you.
I have a question.
Yeah, Mr. Dragon, hope you remember me.
Ada satu pertanyaan, Mas.
Okay.
How does radiotherapy for kidney cancer?
Ada one question, Mas.
Okay, one question from the Ampun Ligaya. This from hospital Sarjito. Yes, Sarjito, Yogyakarta. Yes. How does radiotherapy for kidney cancer differ between primary tumors and metastatic sites? Please, Mr. Dragon.
Thank you for your question. Can you hear me? It's okay. Can you hear me?
Okay. Your sound is clear. Okay.
So, for the radiotherapy in the kidney cancer, as I mentioned, because the kidney cell is more radio-resistant to the radiation. So, for the doctor, they mostly to use surgery and chemotherapy for the first-line treatment in the kidney cancer. So, if the case, let's say, if the kidney cancer is metastasis to another region, so they cannot undergo the surgery, or even the chemotherapy also cannot control the signs and symptoms. So at this stage of the disease, the doctor may decide to use the radiotherapy to control the disease. It's not curative. So normally in Hong Kong, the kidney cancer, we will not treat it in the primary or in the first line of the treatment. Mostly we will treat the kidney cancer in maybe in the metastasis case or in some advanced stage case.
Okay, thank you, Mr. Dragon. So we back to Ms. Ambun. Yes. The
And one more
answer.
thing I can explain more. For us, the metastasis case of the radiotherapy, we normally is using the SBLT because the metastasis mainly in the bone area or sometimes in some liver area. So if the shape of the tumor site is small, we will apply the SBLT to treat the metastasis region. I hope this can answer your question.
Okay, thank you, Mr. Dragon. Oh, so we back to Ms. Ambun. Is there a response for Mr. Dragon's speaker answers? Please, Ms. Ambun, can you respond for answer for Mr. Dragon? Oh, that's enough. And the chat. Okay, thank you. Okay, and next, any question in the chat? Okay, I think question for me, Mr. Dragon. In stereotactic body radiotherapy is interesting method. Yes. What is the main benefit of using stereotactic radiotherapy over conventional radiotherapy? Can you explain to me?
Oh, you mean the advantage? Any benefit?
Yes, advantage or benefit or stereotactic radiotherapy.
Okay.
Yeah.
Because stereotactic radiotherapy is more focused on the tumor. If the tumor site is small, we can focus more on the tumor. And the surrounding tissue, we can keep the lower dose. That means the side effect of the patient can reduce the side effect and the uncomfortable discomfort will reduce the discomfort. But for the conventional radiotherapy, because the treatment area is big, so many organs will affected by the radiation dose, so the side effect may be more than SBLT.
Okay. So stereotactic radiotherapy is the advanced method is in the radiotherapy in radiotherapy.
I think it's okay for the proton, but for the proton, in my center we don't have proton, but I still believe the proton is also can apply for the treatment in the RCC. But I think the role also same as normal radiation therapy is as prevention use for this type of cancer. Maybe SBLT we can substitute by the proton therapy, but the treatment area I think is still for the metastasis bone lesion or liver lesion, something like that. I think it's not the primary or the first line treatment. I still believe it's not.
Okay, thank you. I'm back to Mr. Dedi Junaidi. Can you respond for question for answer for Mr. Dragon? Mr. Dedi Junaidi.
Yes.
Okay. I think it's enough. Okay. Any question on the participant in the chat Zoom or directly question in the Zoom? Okay, I think enough. So before we for the committee or a question for two speakers. Any question? Okay, I think enough.
Enough, Sudi. Thank you, Mr. Dragon. Hello.
Hello, thank you.
Long time no see.
Okay, last week we met Mr. Dragon in ASRT in Asian Radiotherapy Symposium. Hope you remember me.
Oh, of course I do.
Okay, then this is our picture. This and yes. Okay.
Just last 2 weeks in Taiwan.
Yes, 2 weeks. Yes, 2 weeks. Yeah. Okay. I think it's enough for this session. because Mr. Dragon is still in health services activity. And the limit for the time. Thank you for speaker. Before we close to this session, we will to be hand over our certificate. Yes, there will be a certificate hand over to the speaker from the committee. We invite to head of the Department of Radiology, Mrs. Dr. Fatima, to be willing to hand over the certificate of appreciation to speakers. Mr. Dr. Fatima, please welcome.
Ya, terima kasih Mas Udin. Terima kasih Pak Ki. On behalf of the organizing committee, I would like to express my deep gratitude to the first special speaker, Dr. Cik Sugianto, Master of Applied Science, for sharing your knowledge and insight. Thank you for your participation in this event. Terima kasih Pak Ki.
Terima kasih, Pak. Ya.
Yeah. We are deeply thankful to the second our special speaker, Mr. Dragon. Terima kasih for their inspiring presentation during this event. To recognize your valuable contribution, we are pleased to present this certificate as a symbol of our gratitude. Thank you very much.
Thank you very much, Dragon.
Thank
Yeah.
you.
See you next time.
Yeah.
Yeah.
See you next time.
See you next, Mr. Dragon. Thank you very much. Yeah.
Thank you.
And yeah.
Okay. Okay, thank you, Dr. Fatima, to hand offering this certificate. Thank you for all your interesting question and to our speakers for this thoughtful response. We really appreciate to your participation today. Thank you once again for joining us. We look forward to seeing you at our next webinar. Yes. To Mr. Dragon, please let me know. We are waiting for his presence to Indonesia or Jakarta to visit your family. Okay. We waiting you to Indonesia. Please call me. Yes. Before we close all of session in the first session panel we truly appreciate to participant and speakers to share your expertise, your experience for all today. Thank you for joining us, and we hope to see you at our next webinar. Have a great day. We finished for Wassalamualaikum warahmatullahi wabarakatuh. Time and screen. We return to Mrs. Anna, the Master of Ceremony. Thank you.
Thank you so much, Mr. Saifuddin.
One more, Mas Servan, moderator certificate. Yeah. We are sincerely thankful to our moderator, Mr. Saifuddin, for serving as the moderator to today's events. Thank you for building the discussion and engaging the audience to be active in this event. Please accept this certificate as a symbol of our gratitude. Thank you, Mas Udin.
Thank you, Dr. Fatima. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thanks, Mr. Saifuddin, who has guided this discussion today. And we would like to express our gratitude to Dr. Sugianto and Mr. Dragon Hong Long Liu for the amazing presentation in the first material session. And I think what a nice picture between Mr. Saifuddin and Dragon Hong Long Liu. Ladies and gentlemen, that was a great discussion about MRI and palliative radiotherapy for kidney. We want to announce to all of the Indonesian radiographers in this room, don't forget to click Start Learning in your Pelataran Sehat or LMS. And before we go to the next session, ladies and gentlemen, our department have some surprises for the society. Please kindly watch this video about X-ray Machine Conformity Testing Service atau Lembaga Uji Kesesuaian Radiation Protection Officer Service, PPR, and Journal Service Name GMAT.
Can I call you Rose? 'Cause you're sweet like a flower in bloom. Can I call you Rose? Can I call you Rose? 'Cause your fragrance takes over the room. Can I call you darling?
Okay, ladies and gentlemen, the second speaker session, we have Muhammad Hairi Jahidi bin Mahazir and Professor Dr. Lalit Gupta, MSc PhD. In this session, we will discuss about conventional imaging of kidney and ultrasound in nephrology. The second session will be guided by our moderator, Mrs. Marihato Jana, Sarjana Sains Serapan, Magister Kesehatan. So, time is yours.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Good morning and best wishes to all of us. Welcome to International Conference on Technology of Radiology and Sciences, IConTRAS, with the theme Radiology, Modalities for Kidney Imaging. I am Riha and it is my honor to be your moderator for today's sessions, focusing on a topic of critical importance, radiology modalities for kidney imaging. As we delve into these sessions, we stand at the intersection of advanced medical imaging technology and the complex challenges of kidney disease, a key, a non-communicable disease affect wide. The role of diagnostic imaging in the detections, management, and treatment of kidney disease has never been more vital, especially in an era where precision and early intervention can significantly alter patient outcomes. Now, it gives me great pleasure to introduce our next speaker, Mr. Muhammad Hairi Jahidi bin Mahazir, and also Professor Dr. Lalit Kumar Gupta, Master of Science. Good afternoon or good morning, Mr. Hairi.
Good morning, Assalamualaikum warahmatullahi wabarakatuh. Thank you for inviting me today.
Warahmatullahi wabarakatuh. How are you? How about the weather in Malaysia?
Okay, Malaysia currently have heavy rains.
Oh,
So I think bakal banjir. Bakal banjir ya. Saya
yeah.
di Terengganu lebih kepada pantai, beach, more beach here.
Okay, so it's warm, a little bit warmer. Yeah, I hope you're doing well today. And ladies and gentlemen, I'm pleased to present a brief curriculum vitae of Mr. Hairi. and also Professor Dr. Lalit professional backgrounds. So please, the curriculum vitae. Hello, Mr. Khairi.
Hello, hi.
Could you please?
Uh, Assalamualaikum and good morning, everyone. My name is Muhammad Khairi. You can call me Khairi, my nickname. And then I'm currently working as a seniorographer at the Terengganu, Malaysia. And I'm conducting and supervisor in ultrasound modalities. And then I also have one of the researcher in my hospital. So basically, my research about my ultrasound is about the current practice in elastography. So today I would like to present about wait up. Everyone can see my slide.
Apakah slide-nya nampak?
Ada nampak slide kah? Boleh lihat?
Yes, it's
Nampak? Sudah nampak slide saya?
ya sudah nampak.
Sudah nampak. Okay. So hari ini my topic is about ultrasound in nephrography, current radiology practice and essential updates for radiographer lah. So this is my name. So this is my new hospital and your campus, I think. Okay. So for the introductions, I'm sure there's not people are quite familiar with the ultrasound machine, and then radiographer mostly are involved in radiography, CT scan, MRI, but not so many people involved in ultrasound machine. So I will introduce you about a bit about the ultrasound machine. Actually, it was using by the ultrasound wave, and then we producing the image with the gel and also transducer here. So this is our model machine we have here. So this is a very basic machines, and then the system is about something you can diagnose everything inside of this machine. So we have a button here, we have a transducer port, we have the processing unit, we have a main monitor. So main monitor is a light TV, and the operating panel unit is like a tracking ball, like a CT scan. So I'm sure that you see the CT scan, the button are quite same, but the different function. Okay, this is a type of the ultrasound transducer. We have abdominal, high frequency, microconvex probe, phase array, gynecology, rectal, and also visual artificial aversion probe. But for the renal, we only use the abdominal probe. But for the pediatric, we use the microconvex probe. So this is a physics how the component of within the transducer. We have a crystal, we have the wire, we have the scanning window, we have the frame mounting, we have the oil bag of coupling. This is a physics ultrasound machine. Okay, so this is part of very important compartment to produce the image.
Mohon maaf,
Okay, this is
Mr.
the
Khairi. Slides-nya masih
ya,
pause, bisa di slideshow dulu?
boleh boleh kah?
Iya, boleh.
Sekarang sudah besar kan
Bisa di slideshow?
di slideshow?
End show dulu, baru kita tayangkan lagi.
Oh, oke, boleh. Kejap ya.
Yeah, it appears. Thank you.
Is it okay everything? The slide, my slide. You can see?
Yes.
Yes. Is it full? Full version?
Yeah.
Is it full version? Yeah, okay. So I go fast this one. I'm already this one dah saya dah tunjuk tadi kan? Moderator.
Yes. Yes, Hani.
Ya ini saya sudah tunjuk tadi kan?
Sudah tampak besar.
Sampai sini Sudah nampak besar?
Ya.
Sudah nampak besar. Okay, saya start balik Okay, so I start back. So this is my presentation today about the ultrasound in nephrography, current radiology practice, and essential update for radiographer. So this is my hospital. This is your campus. My name is Mr. Khairi, and I'm in charge in ultrasound. So for the introductions, ultrasound actually we are using the ultrasound wave and then producing the image. This is machines, how it looks like the machine we have in our department. But we have a lot of brand, ada GE, ada Canon, ada MyRay, ada Fusions, ada juga Samsung. Okay, so teknologi sekarang semakin berkembang dan kita punya transducer juga agak canggih lah. So ini adalah jenis-jenis transducer we have. So we have the abdominal and microconvex for the renal. For the rest, we are using for the transvaginal, for the ONG, and also for the thyroid. So this is the compartment in transducer. So saya pasti tak semua orang memahami belajar itu pasal ultrasound, tapi diorang lebih familiar kepada CT scan, MRI dan juga X-ray biasa. Tapi ini ultrasound adalah kita punya macam speciality sedikit daripada radiografi yang biasa. But this one I'm sure that tak semua orang belajarlah pasal this part. Okay, so ini adalah butang-butang yang ada dekat ultrasound lah. Kita ada banyak sangat butang, tapi mostly we are using DGC, that kita guna transducer probe, freeze button. So ini adalah 4 buttons yang sangat common kita guna untuk pemeriksaan ultrasound. Ada kidney ke, ada organ ke, kita akan pakai this button lah. Okay, so ini adalah introduction for nephrography and ultrasound application. So saya pasti semua tahu apa itu nephro, lebih kepada kita punya buah pinggang, and then graphy pula adalah teknik our imaging teknik lah. So ultrasound adalah ultra bunyi yang menggunakan sistem bunyi. So ini adalah prosedur ultrasound bunyi buah pinggang lah. Okay, so kalau you all nak practice dekat ultrasound nephrography dekat kita punya department, we have patient preparation, kita ada transducer selection. For patient preparation, biasanya kita akan suruh patient minum air dengan sangat banyak lah untuk pastikan buah pinggang dia cantik dan juga dia punya bladder penuh supaya kita dapat identify a certain disease dekat sana. Untuk patient preparation, it's very easy. First, patient just minum air sahaja. Tak perlu puasa apa-apa, just minum air masak sahaja. Untuk transducer selection pula, kita akan gunakan this convex probe lah. Untuk pediatric, dia akan lebih kecil compared to the adult one. Okay, untuk imaging protocol, saya akan masuk dalam kita punya topik lebih detail. Indication dan juga challenge macam mana you nak scan pula ada dalam next slide saya. Okay, ini adalah contoh antara buah pinggang yang saya dapat scan dekat saya punya department lah. So step dia sangat senang. So you just pointer the kidney dekat you punya armpit punya region, dekat bawah subcostal region. So dekat situ bila you position probe here, you akan dapat this image, 3 image ni. Okay, so 3 image ni adalah melambangkan buah pinggang yang sangat cantik lah. You have to demonstrate all this anatomy. You have to do minor calyx, major calyx, renal pelvis, renal cortex, medullary pyramid, and juga renal sinus. Untuk dapatkan semua gambar yang cantik, you have to practice a lot dekat patient sendirilah. So kalau you all nak practice, biasanya kalau dekat Malaysia, kita akan banyak attach dengan kita punya radiologist dan juga pegawai perubatan kita lah. Okay, ini probe yang saya kata tadi, kita guna curve probe. Okay, next image adalah cara kita nak dapatkan transverse view. Transverse view bermaksud potongan yang pendek lah, potongan yang pendek macam ni. Okay, daripada longitudinal yang panjang, dia turn to the probe. Probe ni akan berpusing dan the image yang you akan dapat adalah pendek macam ni. So kita cut dia punya image secara pendek, sikit. Okay, kita panggil transverse view. Dekat ultrasound kita ada dua view. Kita ada longitudinal dan juga transverse view. Macam X-ray, kita ada epi and also lateral. Okay, so next slide is about the bladder lah. Bladder sangat senang lah, you suruh patient supine position sahajalah. You baring macam biasa terlentang, and then the probe position have to axial, transverse and longitudinal. So transverse, short view, you akan dapat mid transverse view macam ni, dia akan kembang. So that's why you kena minum air masak yang banyak supaya you punya bladder sangat kembang. So for the mid longitudinal view, you just cross the bladder from like this go to the like this. So that's why you akan dapat longitudinal view. So ini adalah cara-cara you measure you punya bladder lah. Okay, so next adalah pathology dan common nephrography punya pathology lah. So kalau you tengok kat sini, ini adalah hydronephrosis. Hydronephrosis adalah disebabkan oleh air yang banyak dekat kita punya sistem kencing, sistem urinary. So dia terapung dekat dalam tu. So kita ada 4 grade. So grade 1, grade 2, grade 3, grade 4. Grade 1 dia hanya masuk dalam sistem pelvic region sahaja. Kalau grade 2 dia dah masuk minor calyces. Kalau grade 3 dia dah masuk major and minor calyces, and the last one bila dia dah kembang sangat sampai ke dia punya cortical nipis small, it's gonna be grade 4. So this one pula dalam ultrasound, this one is the kidney stone. So dalam kidney stone you akan nampak it's a very hyperechoic atau echogenic lesions dekat dalam ni. So dalam renal calculi, bila you ada calculi, the calculi actually is a very dense. So that's why dia punya survey daripada atas, dia kena dekat you punya stone, dekat belakang ni takkan ada image yang boleh dibaca. So that's why kita panggil posterior acoustic shadowing. So kalau dalam topik ultrasound, you akan sangat familiar lah dalam this punya artifact. So next one adalah kita boleh tengok adalah this one is a renal, this one is anechoic lesion. So bila anechoic ataupun hypoechoic lesion biasanya adalah kita panggil cyst lah, so renal cyst lah mostly. Okay, this one sangat common dalam nephrography punya pathology. For the next one, this one is the multicystic renal. You akan dapat sangat banyak cyst yang ada macam-macam size. Variable size kita panggil multicystic kidney lesion. Okay, so this one pula adalah pathology dekat ureteric punya area. So you akan dapat this one calcification. So that's why dia akan nampak twinkle artifact. Ini hanya ada berlaku dalam ultrasound sahaja. So ini pula adalah kita panggil multiple calculi. So biasanya patient yang ada gout atau rheumatoid arthritis, diorang akan develop banyak batu-batu yang kecil dekat dia punya sistem renal. And this one pula adalah pathology kita panggil angiomyolipoma. It's just like fats dekat kita punya renal sinus. And this one pula adalah bladder mass. And then this one is becoming a malignancy punya type of the cancer. So this one kalau patient, kalau you scan bladder, you akan nampak this mass, biasanya kita akan refer kepada HPE result, dia punya result biopsy lah, untuk confirm what type of the cancer. Okay, for the next one pula. So for the next one pula adalah challenges. Biasanya kalau dalam ultrasound buah pinggang, kalau you nak scan, kita ada beberapa masalah lah. Ini adalah masalah yang biasa berlaku lah. Yang pertama adalah patient condition. You have to look, is it patient terlalu besar? Is it senang nak scan? Sangat susah. Sama juga dengan konsep another modality. Kalau patient yang terlalu besar, you have a lot of content dalam dia punya badan. So patient condition ni memainkan peran penting kalau you nak scan buah pinggang. Kadang-kadang kalau patient yang terlalu besar is too big, your renal maybe is a big increased echogenicity. Kalau increased echogenicity dalam you punya renal, we consider as the renal parenchyma disease. Next one adalah bawah gas. So So bawah gas ni sangat senang berada dalam image ultrasound sebab dalam kita punya organ sendiri kita ada bawah gas, kita ada bawah, kita ada stomach. So that one adalah benda-benda yang boleh menyebabkan gambar-gambar renal you tak akan dapat dalam scanning punya part. So macam mana you nak avoid? Adalah caranya salah satu adalah you akan suruh patient drink a lot of water during the procedure. And then patient movement, sometimes patients a bit move like something like move macam bergerak kiri kanan sebab dia geli, maybe ticklish, so that's why they are not comfortable. So you have a challenge to capture the proper image. And then the kidney positions, basically the all kidney in our human body are very different. Some people have too high, some people too low, some people to the posterior part, some people at the superior part. So to get the kidney position properly, to get the image for the kidney, you have to screen first using ultrasound and get where exactly the kidney, and after that you have to focus that region only. Okay, but you have to do a modified technique, which is that you modify the positions of the kidney daripada you supine, you get to the lateral, or daripada lateral, go to the supine or some oblique. Okay, and the skill, this one you have to get from yourself lah. This one you have to collaborate with the medical officer or your radiologist. Okay, so next one adalah, this is a new technology advance in ultrasound nephrography. So this image previously I get from my conference, European College of Radiology at the Vienna, Austria. So I go there and then I see a lot of European people practicing in contrast in renal and also shear wave elastography. So these three methods are very high advanced technology, and I'm sure that for the junior radiographer or sonographer yang try to start the scanning get difficulty in Doppler study. Okay, Doppler study bermaksud you ambil gambar ultrasound dan lihat dia punya salur-salur darah. Okay, this one pula contrast enhancement ultrasound study lebih kepada macam you tengok CT scan contrast. Okay, tapi kelebihannya adalah berbeza compare dengan contrast dekat CT scan. And shear wave elastography study pula dia tengok cara kekerasan buah pinggang itu sendiri. Saya juga telah terlibat dengan beberapa research melibatkan menggunakan shear wave elastography lah. So untuk renal Doppler study, biasanya patient yang nak buat ultrasound dia ada masalah yang hypertension, patient-patient yang ada darah tinggi, patient-patient yang ada post-transplant, pre-transplant. Okay, itu semua patient yang memerlukan Doppler study. So untuk Doppler study ni hanya mesin ultrasound sahaja yang boleh digunakan. Kenapa CT scan tak boleh untuk access renal Doppler? Sebab CT scan tidak sesuai kerana diorang menggunakan kontras. Untuk patient nak buat transplant, diorang tak sesuai guna kontras. Okay, so untuk guna renal Doppler study ni, kenapa diorang sangat berminat untuk renal Doppler study ni? Kerana renal Doppler study ni boleh mengeluarkan value. Okay, cara flow darah itu mengalir daripada sistem aorta ke renal tu. Diorang boleh predict berapa value bacaan dia dekat sini. Okay, this image actually represent patient yang ada stenosis. Bila stenosis you nampak kan dia ada mixing color dekat sini. And then bacaan dia 193 cm per second. Untuk normal punya renal kita bawah daripada 125 cm per second. Okay, so dekat sini pula ada bacaan PSV dengan EDB, peak systolic velocity dengan end diastolic velocity. So dia akan keluarkan bacaan di bawah ini. Okay, ini untuk renal Doppler study for the patient having the stenosis and post or pre-renal transplant. For this one adalah shear wave elastography. Shear wave elastography ni adalah menggunakan satu teknik yang baru dalam mesin ultrasound di mana dia adalah hasil gabungan beberapa kompartmen teknologi, iaitu dia ada 2D, dia ada color, dia ada ARFI dan juga beberapa teknik fizik lain, dan gabungannya ini diorang menghasilkan bacaan di bawah. So dalam bacaan di bawah ini dia melambangkan tahap kekerasan kita punya buah pinggan ada masalah ke tidak ada masalah. Untuk research study current yang saya sedang buat adalah mengenai liver. So mengenai liver, renal saya dah lepas. So, sekarang liver saya dah buat, saya tengah buat liver dan kita uji di mana tahap liver berapa kekerasan dia. Dekat sini value dia akan keluarkan beberapa value lah untuk patient, dan this one boleh measure banyak kali lah dekat this map. Kita panggil elasticity map. This one elasticity map and this one is screen map. Okay, this one adalah new teknologi yang kita sedang lakukan lah. Bukan dekat negara-negara kita juga, tapi negara-negara Eropah sudah lama melakukan this procedure. And this one adalah contoh antara satu prosedur iaitu contrast study, di mana diorang injections contrast melalui vein sama dengan CT scan, and then diorang scan ultrasound dekat lesion tu secara live. Okay, untuk ultrasound contrast, diorang bukan menggunakan contrast iodine ya, tapi diorang menggunakan microbubble. So microbubble bila dia interact dengan ultrasound, dia akan keluarkan satu hyper echogenicity yang warna color orange ni. So this one diorang pakai color mapping punya software dekat mesin yang advanced lah. Dekat mesin yang biasa belum ada, tapi mesin yang advanced sudah ada. Okay, this one adalah salah satu contoh yang saya ambil dekat conference previously, iaitu dia punya mass dekat dia punya liver. Tapi cara bentuknya, ini adalah video yang saya dapat, tapi bentuknya adalah macam ni lah kalau dalam renal. Okay, this one adalah sebagai radiographer, apa yang you perlu tahu, apa yang perlu buat dalam you punya department lah. Ini apa yang saya apply dekat saya punya hospital, dan juga ada institusi yang pernah invite saya. So ini adalah common saya rasa untuk semua prosedur. Number one is patient preparation, number two equipment setup, performing the scan, administer contrast kalau ada contrast, data management, collaboration with radiologists, and documentation and reporting. These compartments are very important to enhance you punya skill. Kalau you berminat dengan ultrasound, ini semua ni you perlu apply dekat you punya diri sendiri dulu, and then try to get the collaboration dengan radiologist. Kadang-kadang sebab ultrasound machine dia tidak berbahaya seperti CT scan dan juga MRI yang beri efek kepada patient. Ultrasound is a very very friendly and independent user. Untuk you belajar, you hanya independent dengan radiologist ataupun pegawai perubatan yang berada di bidang radiologi lah. So dekat sana you akan tahu macam mana kita melakukan ultrasound kidney. Okay, next one, ini adalah research updates daripada European punya study, di mana kita sekarang ni adalah ke arah ke AI, dan juga ini adalah the role of radiographer in ultrasound, survey of national society within the European Federation of Radiographer Society in ultrasound. So basically apa yang saya nak ceritakan kat sini, dekat negara Eropah mereka sudah meletakkan radiographer sebagai sonographer juga dekat diorang punya department. And then Malaysians also do the same thing dekat hospital university like Universiti Melaya, Universiti Putra Malaysia, and Universiti Sultan Zainal Abidin, Kuala and then Universiti UKM. Okay, di sini daripada survey daripada yang diorang lakukan, diorang mengatakan bahawa radiographer should be involved in the ultrasound scanning. Okay, this one is for the research update for your knowledge. Okay, next one adalah education and training for radiographer. Untuk radiographer yang nak masuk bidang ultrasound, saya tak sure dekat Indonesia macam mana, tapi dekat Malaysia kita ada satu guideline. Kita panggil guideline on ultrasound usage in the medical practice lah, yang dikeluarkan pada tahun 2022. And then dekat ultrasound practice ni kita ada banyak kompartmen yang perlu you capai untuk masuk you punya ultrasound punya field. Sebab setahu saya ultrasound punya field is very difficult because you have to do some reporting, you have to do update knowledge, you have to know the pathophysiology a lot, because you have to report everything. Okay, and then education ni, CME ni kita orang kat sini ada lakukan setiap minggu untuk kelas ultrasound, dan juga kita ada monthly and 6 months punya training, and also kita hantar we apply for clinical attachment at other hospital to make our radiographer cum sonographer competence. Okay, I'm sure that I'm not sure Indonesian how they are applying this system, but in Malaysia we are trying to develop the radiographers doing the sonographer fields. Okay, next one, ini adalah kompetensi that you have to fill out for being a sonographer. Okay, this one adalah case study that I'm doing by myself. So this one is how looks like the renal in the real life. Okay, this one is the hyperechogenicity here. We call that iskagli. So this is report that I got, and this one is the indications from the clinics, and then this is the finding how I write, and then this one is the left renal calculus that I'm doing. So basically, when I write the report, the below one is we have a radiologist attached with me after we are doing the scanning or during the scanning. Okay, this one is a renal calculus. And next one, this one is the case study for the patients having the hydronephrosis. Okay, so because that's why I tell you that ultrasound in your field, you have to continue the study. CME, you have a lot of CME or attachment because you have to describe the whole thing. This thing. You're gonna describe satu-satu. That is the attention of biological system. This one you akan dapat bila you are together with the radiologist and you have to reading a lot, very a lot. Okay, this one is her renal hydronephrosis. Then here I say that left moderate hydronephrosis with the hydrourethra suggests CTU correlation. CTU is a CT scan urography. Okay, so this is conclusion that I want to tell that firstly is come from ourselves lah, if you want to training in scanning the renal or not, and then you have the collaboration with the radiologist. If you have the patients, I think you can ask your radiologist or medical officer try to 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 take the transducer and try to scan the patient because ultrasound is not so dangerous, but you have someone to monitor you lah, because I'm not sure that how. But here, if you are not familiar, we call the medical officer are we living together in one room with the real patient, and also we are practicing friend to friends. Okay, we have the continued medical educations 1 week once, and we have a training program. We send the people go to another hospital university, and also we encourage radiographer doing the research in my department. I think that's all from me. If you have any questions, let me know. Okay, thank you, moderator.
Thank you balik, Mr. Khairi.
I buat cepat sikit eh.
Mr. Khairi, pertanyaan dari audiens bisa disimpan dulu. Kita menuju ke speakers selanjutnya. Ya.
Boleh, terima kasih.
Thank you for joining us, Prof. Lalit. How are you feeling? Now we are moving on. I will read the CV for our next speaker. He is a clearly remarkable and also professional in the field of radiology imaging. Prof. Dr. Lalit Kumar Gupta is a distinguished expert in radiodiagnosis and imaging with over 44 years of experience. Currently, he serves as a professor and dean at the University School of Physiotherapy and Radiology at Rayat Bahra University. His academic journey includes a PhD in medical radiology and imaging technology from Thames International University, France, and a Master of Science in Medical Technology, Radiology from PGI Mayer Chandigarh. Throughout his career, Prof. Gupta has made significant contribution to the field with over 40 research publications and has mentored more than 200 students on various dissertations and also research projects. His extensive leadership experience is reflected in his roles as a senior vice president of the PGI Medical Technology Alumni Association and space editor of the Indian Association of Radiological Technologies. Today, in this virtual setting, we have Professor Dr. Lalit Gupta. How are you feeling today?
So nice. Thank you very much. I'm uncomfortable. So good morning to everyone.
My
Right, it is
pleasure.
my privilege and to give the opportunity to present about all the conventional radiology in the nephrology.
Yeah,
So I'm happy to be here on your platform.
Yeah,
So thank you very much.
my
Right.
pleasure. Yes.
Yeah, that's right.
Is this your first time engaging with an audience for Indonesia?
Yeah, that's right. Correct.
Wow, it's Thank you
That's
for
right. Though I have a different type of platform already presented, basically, but this time, first time I'm interacting with you all this radiology community.
Thank you.
So nice.
Yeah.
Thank you, Gina.
Prof. Lalit, thank you very much.
Right. Where's Mr. Gayak?
Yeah,
Hello, how are you? Good morning.
yeah. Thank you very much. It's early morning in India.
That's so nice, so nice. So thank you very much. It's my proud privilege for all this is to be here on this your platform. Thank
Okay.
you.
Thank
Yeah.
you.
It is my honor to invite Professor Dr. Lalit Kumar Gupta to join us. With his vast experience and expertise in radio diagnosis imaging, we are truly fortunate to have him present on the topic of conventional imaging of the kidney. Prof. Lalit, we now can invite you to deliver your presentation.
Yeah. So nice of you. Thank you very much. Shall I share my screen or you will share my screen?
Yes.
Already shared it? Just hold on, please. Just for a moment. It's okay. Can you see the slides?
It appears, Prof.
Yeah, Mr. Guy. Is okay, fine. Can you see my slides?
Good.
It's really fine. It's amazing.
Clear. It's okay.
It's okay, fine. So let's start with my today's topic about all this, the conventional imaging of kidneys. So I will talk first about a little bit about anatomy, though everybody is not about the anatomy of the kidney. I will just have a touch a few one or two slides on this. That it has the two being shaped organs located in the lower back of either side of the spine. Each kidneys have 4 to 5 inches long and 2 to 3 inches wide. And the kidneys are made up of cortex, medulla, renal, ureters, bladders, and the blood vessels. The function of kidney is to remove the waste products and toxins from the body, maintain appropriate fluids and electrolyte balance in the body, control the production of RBC by the bone marrow by producing a hormone called erythropoietins, and it helps about the removal of the body drugs, and it helps also for the formation of the vitamin D. It has the historical prospects basically about the renals in 1896 is discovery by the X-rays. 20s in the IVP is developed is with enabling this to build and the visualization of a urinary tract. And the 1950 fluoroscopy emerged in the dynamic studies like retrograde spirographies. And today is what we have the conventional methods are integrated with the advanced modalities to enhance diagnostic accuracies. What is the importance of kidney imaging? It has the diagnosis. Then we can go for the staging, monitoring, guiding interventions, detecting complications, evaluating kidneys functions, screening research and pre-surgical plan and post-surgical follow-ups. Now let's look towards the X-ray imaging techniques for renal studies. It has the basically one is the projection radiography, second is the tomography, and third is the ultrasound. In the projections radiography, we have two types. One is the static imaging plain abdomen radiography and the dynamic image exploratory radiography like in DSLs. In tomography, what we have the nephrotomography and the CT. CT further classified into two, maybe it a helical CT or it may be dual energy or it is a spiral CT. So you can go for the visualization of the renal studies with the help of CTs. Then go for the ultrasound. These are three modalities basically what we are using for the diagnosis purposes and treatment purposes. Of course, in the nuclear medicine, we have the basically PET scan also is there. And the DTP also, we can do some nuclear medicines sites. We do some investigation for the renal. But as concerned radiology, what we have the basically, these are the conventional radiology. We have the only simple, the plain radiography and the IVP to see the functional studies. So how we have to do the projection renal radiography? It has basically the source, then patient, the table, as well as we can have the image receptors. We're getting all the informations. So a typical medical imaging that uses X-ray to produce 2D images of internal structures of the body. X-ray machines generate high energy of electromagnetic waves like X-rays. So these X-rays are passed to the patient body and tissue rates depending on their densities. So whatever densities is there in the bodies, there is the formation on the detectors. It captures all the X-ray images, passes through the creating in two-dimensional images. In radiology, in general plane radiography, we have two-dimensional images. So static images means taking a single X-ray image of a patient part like a chest X-ray. So how it works? The patient hold still and breath for a few seconds. Then X-ray machine takes a single image of the body part. The image is then displayed on the screen and it go to the printed on the films. So what are the common applications for the plain radiography to visualization of the kidney? What are basic indications about all this is? One, it has needs to detection of the kidney stones, assessment of renal trauma, calcification of parenchyma, evaluation of the kidney size and positions, it causes of the hydronephrosis, and gas in the abdomen and the kidney about kidneys, and the renal masses and renal tuberculosis. So these are basically the plain radiography positioning and techniques, how we are taking about this. The patient mostly in the spine positions and the central ray passes through the umbilicus 1 inch above of the mid sagittal of the body. Then X-ray passes through, and once it passes through, look towards this is the image what we are getting on the X-ray image. So on the plain radiography, we can see very well about the livers. Then we have the right kidneys. Then hepatic flexure is there. Then psoas muscle is there. Basically, then ascending colon is there. Then fifth vertebra you can see very well. On the left hand sides, we can see the spleen. We can see the spleen flexure. We can see the left kidney. We can see the 12th rib of the vertebra of the ribs, and this is the psoas muscles. Then this is a descending colon, and this is the iliac wing. In the plain radiography, we can have this type of anatomical structures only, where we can see about all this anatomical features. So purpose of most commonly used for general evaluation of the kidneys, ureter, and bladders. This is the main function we have to see in the plain radiography. There is a difference between KUB and the abdomen X-rays. In KUB or plain radiography, we can have to see the kidney, ureter, bladders, but abdomen X-ray, the whole abdomen study, like other indications, intestinal obstruction, we can see about all this. It provides a broad overview of renal anatomy, stones, and the calcification within the urinary tract. So look towards the erect view. So sometimes we normally take the evaluate the erect posters where we see the free air. For example, it has a pneumoperitoniums or movement of stone within the urinary tract. So we can see the position of stone once we take the spine pick versus the erect posters. So clinical significance used in the trauma or post-surgical evaluation to assess the complications. What is the advantage of a plain radiography for a KUP? It has the quick and easy to perform. It has the low radiation, can detect kidney stones, bladder stones, enlarged kidneys, tumors, cysts, urethral obstructions. No contrast agent is required, relatively low cost. It has the non-invasive, widely available in most medical facilities. So certainly it has some disadvantages of plain radiography. It has the limited details, so may not detect small stones or early stage of diseases. So no functional information, radiation exposures, may not detect soft tissue lesions, urethral obstructions, may have bladders, wall abnormalities, prostate tissues. Image quality can be affected by body habitus, bowel gas, or faces of patient movements. So after a plain study, we have supposed to switch over to the dynamic images. So dynamic images means that it taking a series of X-ray images in rapid sessions to show movement or changes in the body. How it works, the patient may be asked to move, breathe, or swallow during the exams, or X-ray machines takes having multiple images and quick sessions. The images can be played back to the loop to show movement or changes. Remember, you have to take a dynamic studies about all this. So it includes IVU and the DSA. Let's look about the dynamic imaging. Excretory urography, the first important attempt to explore the excretory function of kidney was undertaken in 1923 by Earl Osborne, who developed intravenous pylography at a Mayo clinics. It is a medical imaging techniques that uses X-ray and contrast media to visualize unit rect. Other attempt includes retroperitoneal air installations and the nephrotomography. So retroperitoneal air installation based on the concept that air in the retroperitoneal space and the nephrotomography combines the use of IVP with the body section of retinography in the attempt to exclude surrounding abdomen contents from the region of interest. So have a look towards now IVU, where we can have a dynamic study of the renal renal studies. So IVU is a radiological procedure to visualize the urinary tract abnormalities consisting of kidney, ureterus, and bladders after injection of contrast. Functional study by excretory system. A series of radiographs are taken after intravenous injection of the contrast medium a specific interval of time. So what are the common indication for IVP? The common indication is evaluation of a renal function, detection of kidney stones, diagnosis of hydronephrosis, evaluation of a renal masses, assessment of renal trauma, diagnosis of renal tuberculosis, identification of congenital abnormalities, evaluation of polycystic kidney diseases, PKD, then detection of renal scarring, and pre-operative planning for nephrectomy and identifications of renal calcifications. These are the very common, most common clinical indications while performing of the IVPs. Of course, including that now these days, the CS cervixes cases in case of a tumor in the bladders is also performing on the IVPs. So for that, it is needs some preparation is required for this IVP. Patient information consent, explain the procedure and obtain consents. So patient history and screening is very, very important. Allergy has to be checked because we have to inject the contrast media to a patient. The renal RFT test is very, very important to see the kidney level, what creatinine level is there of the kidney, and medication review and the status is there. And need a bowel preparation. This was the small preparation informations and consent is there. So bowel preparation is required, dietary restrictions, a light meal the evening before the exam, and the fasting for 6 to 8 hours before the procedure, and need some laxative medicines also required to removal the fecal matters as well as the bowel clearance. So Delcolex and the charcoal tablets normally gives for all this is for the absorption of gases and the removal of the fecal matters from the abdomens. Avoid of the gas formation of the fluids and the foods. So for this, hydration is required. Depth of a procedure, you have to see the clothing and the bladders, and then intravenous line setup is there required. Then this is very, very important because we are injecting the contrast to a patient. We need to emergency preparedness is required, and psychological comfort should be there to the patient. Special consideration for the pediatric patient, diabetic patient, and the elderly patient. There's the basic precautions we have required before start of the procedures. So for that, we are injecting the contrast media. So normally we have to, ioxal is a non-ionic contrast media we are using to for this to enhance the visibility of the excretory system. It is a non-ionic contrast agent, water solubles, iodinated contrast agents, and administrated by the IV. Always check level of expiry date of contrast media. Very important before injecting. We have to take some precautions and the preventions. So we have to check the levels for expiry, determine the appropriate amount of loaded and the possible amount of contrast media to limit sites. So IV bolus injection within 30 to 60 seconds and accurate time of contrast injector has to be noted. So this is a small examination preparation. In that, we have to ensure before injecting contrast media, ensure emergency drug cart is stocked and available in the room before any contrast media procedure is taken. Cardiopulmonary resuscitations, equipments, portables, oxygen mask and oxygen sport materials like that, defibrillators and monitor needles and syringe must be ready for them in the room in case of emergencies. Now, what is the film sequences to visualization of the kidney in the case of IVP? In the plain, in the adults, normally first we take the plain film, then 2-minute film, then 5-minute, 10 minutes, then with the compressions, then 11-minute film to compression has to be released, then 15 minutes in prone film, oblique. This is a sequence of film what we are taking. Then lateral film, post-wide films and delay, if indicated. In case of children, we normally take the plain film, then we go for the 7-minute film, then 15 minutes, 30 minutes, 1 hour, 2 hours. So oblique film if indicated, So as per the clinical finding of the patient, then post LASIX and 10 minutes and 20 minutes films. So look towards the plain film of the KUB. Using in assessing calculus, abnormalities, calcifications, abdominal mass, foreign body to check the exposure factors and positioning to check the bowel. So look towards the plain films, we can see about all this in the right and left kidneys and the liver and spleen is there. It's already shown in the plain film. This is the main thing to check the factors and to see any calculus is there. This is the idea to take the factor. And 2-minute films to opacify the renal parenchyma is there. So nothing else because the contrast had to be reached for 3 to 5 minutes to reach in the contrast in the pelvic regions of the kidneys. So these are the 5-minute films we had to take for to see the pelvic systems. In 10-minute films, you see the whole the ureters, the visualization upper third ureters is already filled with those contrast, produces partial ureteric obstructions, resulting in more complete distension of collecting system, improved calcium and more reliable ureter opacifications upon release of the compressions. Then 11-minute film, when compression is released, shows the urinary whole tract system is there. You can see the ureter, bladders is there, ureter is there in the right and left kidneys. You can see about all this is. And look towards the 50 minutes in prone film. Required if the lower part of the ureter is not visualized, then in released films. So in 30-minute films, you can see about all this is. It is the full bladder film is there. It gives complete overview of urinary tract, kidney, ureterus, bladder, and their distension is there. Of course, there is the left side kidney is it is not functioning but properly, but not visualization of the ureterus is there. So sometimes we take the oblique view, project the ureters away from the spine and to separate overlying. Sometimes the stone is overlapping with the other organs. So we can have to see to take the whether the stone is already in the ureters or in the kidney or some outside of the kidney. So that is the idea to take the oblique views of the film. And similarly, the bladder also, the bladder anatomy, such as shape, size, and position of the bladders, one, and vesico-vaginal fistula, diverticulums, bladder herinus, and the CA unitary bladder, CA sub 6. Normally, we take all this the bladders. It is required for all this. This is a later film of bladders. It would not take takes. Then the last film is we normally take the post-avoid films, means to see the residual urine volumes, bladder mucosal lesions, verticula, bladder tumors, and outlet obstruction. So this is we can see a functional study of the kidney by using in the conventional methods. So of course, these are the few pictures normally takes about with the help of, this is the unopacified ureters. You can see about all this is a complete bladders well opacified, right and left ureter is there. Then here is also there is an obstruction is there. We can see with the help of IVPs, and it has a duplex basically about the collecting system in the renal system is there. Then it has the tuberculosis, of course, and destroy right kidney in a patient having the renal tuberculosis. So delay films we normally takes whenever there is an we can say when the kidney is not properly visualization or it has a renal failure cases, taken 1 to 24 hours after injection. Usual of delay films 1, 2, and 4 hours, 8 hours, and 24 hours. Obstruction where any early nephrogram is seen, collecting system does not appear. Then congenital lesions like non-visualization upper calyces system picture here with ectopic and obstructive ureters. Also give important information urologist on how severe on the obstruction is. What is the advantage of IVU now? Right. So we have some advantages of IVG. That is, we have detailed images, and we need a functional informations and detect a wide range of condition like a kidney stones, ureter obstruction, and bladder tumors. It has a relative cost as compared to other modalities. It has the guides treatment and wide availability is there. So if some advantages there, certainly it has some disadvantages also of the IVU. It has this radiation exposure, although relatively low as compared to other modalities, but radiation exposure, then plenty of exposure we have to give because number of exposure we have to take the number of films. So contrast agent is required, may not detect the soft tissue lesions for subtle abnormalities. It has the limited evaluation of surrounding tissues, patient preparation required, and discomfort and replaced by the other modalities. Now these days, basically, IVU is switched over to the CT IVU. So other modalities, what we have basically the imaging modalities to visualize of this is DSA under the real-time studies is there. So principle of, we can say DSA is nothing but is a digital spectrum angiography. It has the some scout film, then to take the angiography film, then after scout film, whatever the same information, it extract the images and in the form of angiography to specify the blood vessels where condition of patient, no movement should be there. So in conventional subtraction technique, what we have basically to visualize the kidney, this is like a duplicating machines with subtraction light, make a positive mask, the first film and the angiography sphere without contrast. So place unexposed subtraction film over emulsion site over this selected mask image. Expose the subtraction light approximate 5 seconds, then depending on type of machine, then unexposed subtraction film is run through the film processor and become a positive or reverse image of the mask. If look towards this, the picture is like this. This is the first image we have taken is a mask image, then is a contrast image. Then after contrast image, the extra informations, what is that we have extracted in the form of the positive mask and reverse image to see the visualization of the kidneys there. So these are the subtraction films is there. We can see the well visualized of the renal arteries and of the kidneys. So with the help of angiography, we can, is a conventional method basically. Now these days conventional method is absolute. They go for the DSA directly about all this. So we have the linear axial tomography in the conventional method also. The tomography drives the Greek word tom to cut, the graphene means to write. The principal tube and the film move synchronously in opposite directions during exposure, where is kept motion, and use the axial tomography, where we get having the tomography nephrology, where the mainly through the technique called nephrotomography. So nephrotomography consists rapid injection of a contrast followed by the tomography. During the IVP, we had normally take the nephrotomography in case of the compression films. So what are the indication of nephrotomography? Cyst, it had demonstrated to damage, it had detection of parenchyma scars, renal tumors, abnormality, horseshoe kidney, pelvic kidney, poor contrast concentration, and renal trauma. So these are some breakthrough of the tomographies. So these are the few pictures what we have taken this with the help of this tomography. So this is the blurring the upper and lower images. So we get the exactly a renal margin pictures we have already received. This renal pelvics and minor pelvics reason is there. So this is the actual picture is there. This is the trauma. This is the nephrotomogram picture is there. Advantage of nephrotomography is it has enhanced diuresis from the additional contrast media and water volumes will distend the collecting system and ureters more fully. Collecting system is utilized for longer times, no significant increase in contrast reactions, ureteric compressions need not to be used. It has some disadvantages also. It has the overload patient with the more iodine than the necessary. Calcium blunting may be produced, suggesting abnormality dilatations may lead to pilocyanosis, extravasation, and pain in patient and with partial obstructions. Increased diuresis may increase visualization of a low fixed specific gravity because it has some sort of that complication comes once you're performing the nephrotomography. So of course, ultrasound, recently I was listening about the ultrasound also, right, that topic. And my co-partner has already explained about the ultrasound. Of course, ultrasound is the best modality now these days also because there's no radiation inside. And this is the first modality of choice of to visualize of any tumors or any obstruction, not as an obstruction, but you can see the hydronephrosis or the renal stones about all this is with the help of ultrasounds. So CT also probably we have the now these days. Ultimately, we switch over the CT mathematical concept known as the image reconstruction images. So CT urography now is performing now these days to visualization of the kidney. So which urographic problems? Urological problem including urethrolysis, renal masses, renal tract infections, and trauma obstruction uropathy. The CT will give the first preferences about now these days about all this is. So CT urography defined as the examination of urinary tract of the excretory phase following intravenous administration. It assess of entire urinary tract consists of 3 phases. One is a cardiac medullary system, 25 seconds delay. then nephrographic phase, then it comes a 40 seconds delay, and the excretory phase, then 10 to 15 minutes delay we can see about all this is. So we can see about the CT radiography with the help of these techniques also. MR also, we can see the probably somebody will cover up MR radiography also about all this is. Similarly, we can visualize the kidney with the help of MRI, which is well visualized about the unit tract system with the help of MRU. So this was my topics. Thank you very much. So
Yeah, thank you so much for
so
Lalit
try
for
to cover
your
up a little bit about the.
delightful presentation. Thank you so much. We are very impressed.
So nice. Oh, thank you very much, ma'am.
Yeah.
Okay.
As we come to the end of these insightful sessions, for those who have my questions or would like to engage further on the topic, please feel free to ask. Use the chat room or Q&A features on Zoom. Or maybe you can raise your hands and ask directly with Professor Lalit and also Mr. Khairi.
Hi, Prof. Lalit.
Yeah.
Hi, Prof. Malaysia. Actually, Prof, you are lecturer at the Bahra University, Chandigarh, is it?
Yes.
Oh, I
Yes, Mr.
just
Kari. Yes, I'm from Bara University. That's right.
yeah, Prof. Sorry, I just want to ask, is it ultrasound have more? I mean, the program ultrasound in the University Bahra there?
We have ultrasound. So we're performing ultrasound on a patient in my hospital, right? And there's no problem at all. Yeah.
Oh, okay.
So
Okay. All right. If we want to, I mean, that's collaboration with the Bara University Chandigarh. How to reach you, Prof? How to reach you, Prof?
Far away,
It's not a question. It's about more.
Very far away.
It's more to public relations. It's not a question.
certainly we can have a sit together and we can have
Yeah,
some
yeah.
sort of that discussion can be there on what all this is. That is very interesting.
Business
Basically, yeah.
relations.
We love to see about some sort of exchange programs, academic exchange programs.
Yes.
Right. This
Yes.
is your
Hi,
reason,
Mr.
basically. This is good.
Sugianto.
Yes.
Hi,
Um,
Mr. Sugianto. I forgot to introduce myself to you. I'm so sorry.
It's interesting, Mr. Khairi Jahidi. Yeah. We are going to have a sonographer also in Indonesia. Right now,
Nice.
progressing. Yeah. Some centers already has a sonographer. Is to be a radiographer and right now a sonographer. Yeah.
Very nice. Very nice.
Yeah.
That's good.
Very nice.
I think it's
Yeah.
very
Because
good.
there's a lot of development is going on in the field of radiology. Right.
Yeah. Correct. Correct.
So in need of lot of calibrations among all this, so that in research projects, in the academic activities, how we can proceed further. Because research is also very important factors basically now these days.
Yeah,
Right.
correct. Yeah.
So that is the issue.
Yeah. That's very nice. Yeah. Question kayaknya, Mbak.
The first question, heading on to Mr. Khairi from Mrs. Halinda. Usually, beginners have difficulty finding the organs they want to see and seeing the image results. For example, the left kidney is sometimes covered by the ribs, or the image results look the same, but the color is almost the same, right? And how to learn ultrasound for beginners. Please give some advice on how to learn ultrasounds so that beginners are very enthusiastic about learning ultrasound. Maybe the question from Mrs. Halinda is dedicated to her students. Yeah, thank you so much.
Okay, actually, for the basic ultrasound, first is come from myself. This is I talk about how I'm doing the ultrasound at the first. It's come from myself, and then when it's come, it's from the patient first. It's from the patient, and I'm start reading, And after that, I'm trying to attach with our medical officer. Starting from there, I gain a lot of knowledge from them. Because in radiographer, you know the techniques, how to scan, how to modify the machines. But in terms of medical terms or pathophysiology, you have to learn from the medical officer. So when you combine your techniques and medical officer knowledge, you combine together and you try to relate with the ultrasound's procedure, you know why the image is looks like that. Okay, and then for the questions about the read, quite difficult for the certain patients to visualize the kidney. First of all, you have to see the decubitus of the patient itself. If the patients are quite big, you have two options. Number one, you ask the patient do the semi-erect positions and scan to the lateral side of the kidney. Basically, left side is more difficult compared to the right side. Okay. Number two, you have to inside the patient breathe in and hold, because when you breathe in and hold, the diaphragm is going down and then the kidney also going down. Okay. And another techniques, you have to find out the interspace between the rib itself. You have to get the dedicated transducer to put between the rib itself, get the window to penetrate the kidney. This is another method. Okay, for the beginner, as I said before, first is count for your patients. Secondly, you have to collaboration with the others, and then you need to update your knowledge. You have to reading a lot about the pathophysiology, radiopathology, because from there you will get understand more compare you just do. You have to do all these things to get the sonographer. Is another knowledge you have to reach. Okay, this is my advice, because not all people are very interested in ultrasound. Not all, but some people, when they are when they are starting touching the ultrasound, they develop the interest. Thank you.
Okay, so the key point on how to finding the live kidney is about the breathing instructions and also the positions, right?
Yes, the position. So, and then try to inside the patients drinks a pint of water, because you can reduce the bowel gas.
Okay, that's
Okay.
clear enough. Thank you. Yeah. Mr. Hairi, have you any experiences in handling on the breastfeeding or lactating woman, especially to detect the small lesion?
For the breast, is it? For the breast
Have you
imaging
any
or for the
experiences
kidney?
on a breastfeeding moms to
Okay,
detect
breastfeeding.
a small lesions? Have you?
In in which procedure? I mean the kidney or which organ? Breastfeeding woman. I have a lot of patients with a breastfeeding woman. If in different imaging for the breast imaging, the position, the anatomy of the breast is different compared to the normal one. So you have to know the patient condition first before you start the scanning. That is the question for the organ breast. For the kidney, basically, there is nothing issue for them to drink of water or what kind of water. It doesn't matter. Okay.
Yes. Thank you for the explanations. Maybe we are
All right.
going to the Prof. Lalit. We have some questions here.
Yes.
Yeah, Prof. Lalit, has the use of conventional examination in India shifted towards advanced modalities such as CT of MRI, for example, IVP in Indonesia shift to CT urography? How are educational institutions addressing this phenomenon, especially given that certain conventional examination competencies taught in this institution are no longer practiced in hospitals?
Absolutely, absolutely. Because today's the modern era, basically, this was the previously people are doing the IVPs, right? The conventional radiology, basically. But you can't forget about the conventional radiology. It will remain there only. These are the basic things. You can't forget about the plain KUB. You can't forget about all the other investigations. Yes, CT and MRI has replaced IVP, right? So all the institutions is performing now CT urography and MS urography. This is the first not choice. But after first KUB, plain radiology, then go for the ultrasound, then go for in case they feel any, even renal stone. You see, the renal stone, even ultrasound is not very successful. For renal stone, now the choice is the CT scan. So they take the multi slices and take the thin slices and visualize the kidney stones. In that case, once you find out the kidney stones, IVP is not required, right? So your question is regarding the replacement of CT and MRI with the IVU. Yes. Now these days, because the modern era, people are in all the medical in the institutions where the facilities available, CT or MRI, it is all choice. They choose and do the IVU accordingly. Because nowhere is using the tomography. Simple tomography people are not using now these days. IVP is a very few centers they are performing IVU because in case of CS cervix and all these cases only up to that level only. Rest all the investigations, all the procedures like RCC, renal cell carcinoma, like the tumors, we can say renal tumors. This is the best choice is the either the CT or the MRI.
Yes. Prof. Lalit, with technology advancing so rapidly, is there a research recently have you developed for the kidney stones imaging?
Yeah, for kidney stones, that's right. Choice of first is ultrasound because there's non-radiations. Then go for the CT scans. Then you can have the reconstructions of the very thin slices with the help of the CT scan and find out the renal stones, whether in the urine, the bladders, or the kidneys, and the location and the position of the stones you can find out. This was your question.
Yes. And how about perform a safe radiological kidney in patient with abnormal urea and creatinine levels?
Ideally, should not be more than 2 creatinine. All right, the level of basically of the because of if after 2 the level of the degree is 2, that is for creatinine level is 2, then it is slightly high risk. But should be below 1.2 is the ideal recommendations point. It should be less than 1. It should be less than 1. The creatinine level should be 1. Then it is one safe. Two type of safety is what I'm reading this question. Two type of safety is basically required. One is the radiation safety. Second is the physical, the patient we are supposed to injection the contrast media, right? So in that case, we need that safety is required. As concerns radiation safety, we have to be very careful about all this. We should not expose unnecessarily to a patient. The proper collimation, proper filtration, proper type of detector compatibility should be there. High resolution equipment should be there. High power equipment should be there, right? As concerned CT, yes, of course.
Yes. Thank you so much for the explanation. But we have a two maybe sequence here. And how about angiomyolipoma? I never been here. It's about the disease and how to
Angiomyolipoma. Angiomyolipoma.
Yes.
Is question to me?
Yes.
Yeah, the question is about the angiomyolipoma in the conventional radiography.
In conventional radiography, this is the one of the indications. But I'm talking about the only indications. I'm not talking about like a lymph nodes also. Sometimes we have to do the lymph node and CT scan also. But lymph nodes is the first choice is CT only, right? But I'm talking about only the indications of the renal studies. In that case, we're performing of the IVPs. But it is totally replaced nowadays with the CT scans because conventional radiology is totally changes with the new modalities like CT and alls.
Yeah. And one more for Prof. Khalid. Yeah. When we are performing a 3-phase or 4-phase contrast CT scan in case of hydronephrosis. When we are performing a 3-phase or 4-phase contrast media for hydronephrosis.
You're talking about CT or conventional?
CT scan.
CT scan. Okay. Well, this is the basically normally in my centers we are performing about only a three-phase CT scans, not four. Okay.
Yes,
In
it's
case of hydronephrosis cases, yes. In case of conventional radiology, we have in hydronephrosis cases we have follow up for 1 hour, 2 hours, maybe up to the for 24 hours to see the function of the kidney. In that case, yes, we have to go for long terms.
Yeah,
We
that's
consume
all.
we
Yeah.
consume the long times in case of conventional IVPs and all. Till the visualization of kidneys is not there.
Yes, that's all. I think all the questions is very impressive. Thank you so much, Prof.
Okay, so nice. Thank you very much.
And maybe the other audience wants to ask to Mr. Hairi.
You see, they can if they have any question, they email to us. We give the reply.
I would like to inform the audience if
Right.
we need
So they
more
can send the mail to
questions.
us, so we can have a communicate to them
Yeah.
according to their questions. In case there's a need of more clarifications or more information is required for the conventional
Thank you so much. It's been very
renal
helpful.
systems.
Yes, maybe for Mr. Hairi, I want to ask something maybe outside the substantial. What inspired you to focus on this area? What have been most exciting part of your journey so far as sonographer and professionals radiographers?
Yeah, I like be a boss actually. Okay, number one is I like to be a boss because a sonographer you have to be number one is you independent user. Independent user. It's not same with the X-ray or CT scan. You depend on the machines, how they are set up. But in the ultrasound you have to depend on yourself and your skill itself. So when you are polishing your skill, you get more knowledge, and after that you my assignment actually because of I can collaborate with a lot of specialists in my center, in surgery part, in orthopedic part, in internal medicines, in the ONG part. So when I do a collaboration with them, I get a lot of knowledge from them. So from there I develop a new skill, a new update knowledge, and also I can get a new technique, more advanced new technique, such as the in musculoskeletal system. Basically, basically if you are general sonographer, you just get the abdomen, thyroid, something like that. If you go to advanced, you can get you can be like them. You can be like a specialist, but you are not doctor. But you can be like a specialist like them, and you can do a reporting like them. Okay, just you need the approval from them. After that, after you do the report, everything's, and then you just ask them, is it okay my report? And after that, it's just approved. So because I said before, because I like be a boss actually, it's not I try to bangga bukan, because I like to be like a boss, and I like to be like a teacher. I can teach when I have a lot of knowledge, I can teach others. So from there also is my contribution actually can develop others sonographer join my team, something like that, you faham tak? So because of that, uh, the sonography field I think is benda yang the things that not all can get kalau you tak berusaha. So bila you berusaha, you get and you share with the others. So you akan dapat you punya ilmu, you gonna be gain a lot of knowledge. Okay, something like that.
Yes. So the
Jana, this is
private
the I'm telling. I'm more
is
getting
your
more clear.
power to strengthen your energy to boost your skills and also knowledge, right?
I will
Yeah.
add to in this Mr. Zaidi just say
Yeah.
about the ultrasound. Now these days ultrasound become a very vast subject. Very vast
Yes.
subject. Ultrasound plays a very important role, not on the diagnosis but also treatment also. Right.
Yes.
So it has a musculoskeleton is coming up in the ultrasound. It's a coming up field
Yeah.
totally in the ultrasound. It is a very vast subject and needs
Yes.
a lot of knowledge and
Yeah.
specializations. abdominal ultrasound is different, vascular ultrasound is totally different, right? Musculoskeleton is a totally
Yes.
different about all this is, right? So that type of an ultrasound, it is a tremendous change in
Yeah.
ultrasound studies. Now it is not limited up to the abdominal studies. It goes a very vast subjects, right? So we
Correct,
have to
Prof. Yeah.
keep our knowledge
Yeah.
update accordingly, according to
Yeah.
situations, right?
Yes,
So
correct,
nice,
Prof.
thank you.
Yeah, and
Yeah.
because currently ultrasound, as like Prof said, that is one of the treatment. In MRI, we have a high intensity focused ultrasound. We are using the ultrasound to burn the fibroids, and also we have the another successful treatment in Malaysia from hospital in IConTRAS, Malaysia. They are using the ultrasound to cure the lesions without doing any open surgery.
Yes,
Yeah.
it's for
Okay, they are
treatment
not
also,
doing
like before.
no cutting at all, no cutting at all. It's just from inside
Yeah, yeah,
burns.
yeah, yeah,
Okay,
yeah.
Yeah.
By
that's
the
one.
interventional procedures. Thank you.
Yeah. It's a great
Yeah.
experience to share each other. Maybe we can create another webinar on the future, right? Thank you so much. Maybe we
Yes.
So
have
nice.
to
Thank you very much.
wait
So
our
nice.
Thank
So
you.
time.
great.
Thank you, Prof.
Yeah.
Thank you, Dr.
Thank you so
Fatima. Thank you,
much.
Mr.
Thank you,
Prof.
Mr.
Sugianto.
Gaik,
Khalid,
Suganto.
Thank you,
Khalid,
Mrs.
for your
Mali.
insightful presentation. We are very appreciated.
So
Yeah.
nice. Thank you very much. Bye bye. Take care.
Ladies and gentlemen, as we come to close of this session,
I think one question.
yes,
I
I would
think one
like
question.
to um,
Is there any one question I think I want to answer from, I'm not sure, from VCBC, is it? She asked me about the AI for the kidney ultrasound
okay.
examination.
Is there any advancements in AI for kidney ultrasound examination? Yes, please.
Oh yeah, the AI actually is like a algorithm that we are using in the system in software. That we have a lot of AI in current practice. In CT scan also have, MRI also have. So the function of AI actually try to reduce a lot of artifacts, something like noisy, something like dirty, something like that. They are trying to remove it. It's like you're doing the VRT in CT scan, something like that. And then we are doing also the ultrasound to enhance the renal itself. Okay, this is how AI work out. That is my answer.
Yeah. Thank you, Pak Khairi. And the last but not least, we have a questions for Mr. Sugianto. Bapak, ada pertanyaan untuk Bapak. Pemeriksaan apa yang dilakukan untuk mendeteksi patologi ginjal pada pasien dengan obesitas? What an imaging for detecting the kidney disease for the obesity patient.
Ya, jadi memang nggak apa-apa ya bahasa ya, saya jawab ya.
Boleh, Bapak.
Untuk pemeriksaan MRI untuk pasien obesitas ini sangat-sangat challenging ya. Challenging-nya karena memang magnetic bore-nya ini sangat terbatas. Jadi magnetic bore itu ada kaitannya dengan Tesla. Ya. Nah, artinya kalau kita menggunakan superconducting, kalau Tesla-nya makin tinggi, magnetic bore-nya itu biasanya makin kecil untuk homogenitasnya biar bagus. Nah, sekarang yang superconducting sudah ada yang magnetic bore-nya itu bisa 75 cm ya. 75 cm. Dengan magnetic bore 75 cm ini memungkinkan, bahkan kami lihat kemarin ada anak didampingi orang tua di dalam itu. Ya, ditemani orang tuanya, kakeknya gitu pada saat pemeriksaan anak itu, dan gambarnya tidak mengganggu. Nah, ini challenge memang untuk yang MRI untuk yang gendut ya, yang obes. Alternatif lain barangkali menggunakan MRI yang open bore ya. Dan open bore ini kan tidak akan tidak terbatas untuk obesitas itu. Nah, walaupun ketinggiannya juga kadang-kadang cukup mengganggu ya antara bagian bawah dan bagian atas itu. Jadi memang sangat challenges ya. Biasanya kalau begitu pasiennya gendut sekali, susah itu masuk ke dalam bor itu. Ya, alternatifnya tadi ya, mau pakai open atau mau pakai yang MRI yang dengan 75 cm. Sudah ada beberapa ya yang monitornya segitu. Tapi kan berarti harus pindah pasien ini. Gitu. Termasuk tadi kalau misalnya untuk pemeriksaan diabetes, tadi ada pertanyaan gitu ya, pertanyaan diabetes. Tadi MRI ini bisa untuk melihat struktur, tebal tipisnya parenkim, mikrostrukturnya dengan diffusion gitu ya, atau barangkali oxygenation-nya dengan bolt itu bisa. Ya, jadi memang dari beberapa jurnal itu masih belum firm ya, artinya masih banyak penelitian terkait dengan itu. Jadi kalau barangkali teman-teman terdorong untuk ke sana, sangat-sangat menarik ya, bagaimana memanfaatkan bolt ya, diffusion ya untuk pasien-pasien diabetik itu. Ini masih challenging ya untuk penelitiannya. Itu sih ya barangkali dari saya.
Baik, Jihan, MRI examination for obese patient is very challenging. The higher usage of the magnetic fields, Tesla is the more difficult to hide or to achieve homogeneity. Another alternative is to use open bore MRI. That's the Mr. Sugianto wants to answer to you. Ya, terima kasih Pak Gi. Ya, saya rasa pertanyaan untuk Pak Gi ada lagi atau cukup? Cakap? Ya, cakap. Ya. Alhamdulillah, that's all about the Q&A sessions. As we conclude, let us carry forward the lesson as perspective gained here into our respective fields about the kidney imaging radiologists. Thank you so much once again to Professor Dr. Lalit Gupta, Mr. Khairi, Mr. Sugianto, and we invite you to accept the certificate from Dr. Fatimah Sarjana Sains Terapan Magister Kesehatan.
Ya, terima kasih Mbak MC. Thank you very much Mr. Muhammad Khairi and Prof.
Thank you, Dr.
Lalit Gupta. Terima kasih. Yang pertama untuk Mr. Khairi dulu ya Mbak. Ya, oke. Terima kasih Mr. Khairi. Your presentation has beautifully wrap us to this program. We sincerely appreciate your contribution and are pleased to present this certificate as a symbol of our gratitude. Thank you very much.
So nice. Thank you very much.
Thank you, Doctor.
With great respect and gratitude, we present this certificate. My speaker, Prof. Lalit Gupta, thank you very much, who has his knowledge with us. Thank you for your presentation of the material and expertise has enriched our event, and we greatly appreciate your time and dedication. I hope this collaboration will continue. Thank you, Prof.
So
Lalit.
nice. Thank you very much.
Thank you, Prof. Lalit. Thank you, Dr. Khairi.
Pak Ki sudah terus membersamai kami.
Terima kasih.
Yes, thank you once again.
Finally, Mbak MC, we are sincerely thankful to our beautiful moderator and head of committee organizing, Mr. Marihatul Jana or Mbak MG, for serving as the moderator for today's event. This certificate is a small token of our appreciation for making this event memorable. Terima kasih Mbak MG.
My pleasure, matur nuwun sami-sami. Thank you once again to our amazing speakers and to each one of you for joining us. We look forward for seeing you at our next event. Wishing you all wonderful day. Thank you.
Thank you.
Thank you very much.
Ya, terima kasih.
We'll keep in touch. Bye. Take care.
Ya,
Right, Mr.
Ya.
Thank you. We would like to express our gratitude to Muhammad Khairi Jahidi bin Mahazir and Professor Dr. Lalit Gupta, MSc, PhD. and also to Mrs. Marihato Jana, who has guided the presentation of the second session. Ladies and gentlemen, as our promises today, the committee have special thanks to the lucky participants. Who is them? The committee can help me to show who is the lucky participants today. Who are they? Okay. The name of the lucky participants today first. The first registered participant, Putri Ayu Amelia from Jakarta Barat. The second is the participants with 2,700 kilometer from Aceh Selatan. Wow. He is Ripto Sarwidi. And all of you can open your camera. In the first and the second discussion, we have Embun Ligaya AM Derat, Dedi Junaidi, Andi Imam Manggabaran, Isvan, Halinda F, Sri Mulyati, and the last Jihan Rai Hannah Salsabila. Congratulations to all of the lucky participants. All of you can contact Mr. Ervan Shah for the door prize. He actually part of the WhatsApp group for the participant of this event. So, Mr. Ervan Shah, can you chat your number? Okay, thank you. Ladies and gentlemen, before we close the event today, to all of the participants, would like to fill in the post test. For the radiographers, all of you asked to fill the post test and evaluation in the LMS. And for the others, for students, foreign participants, you can fill the post test that provide in the room chat Zoom. Okay, the committee can to show the link for the post test in the room chat Zoom. Ladies and gentlemen, that was the end of the event. We would like to thank the participants who have attended and participated in this event. And thank you to the director of the Poltekkes Kemenkes Semarang, PP Pari, and all of the staff for participating and supporting the second IConTRAS 2024. And also, we wanted to say thanks for all of the speakers today, Dr. Sugianto, Professor Dr. Lalit Gupta, Mr. Dragon Hong Lung Liu, and Mr. Muhammad Hairi Jahidi from the speakers. I'm Ana Setiana as the Master of Ceremony, and behalf of the committee, would like to apologize if there are any mistakes in holding the second IConTRAS 2024 this time. And last word, wabillahi taufiq wal hidayah, wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih, luar biasa. Semoga berkah selalu. Amin.
Terima kasih.
Terima kasih. Ya, Mas Hairi, Mr. Hairi. Ya.